Buenas noches, estoy Dr. John Bennett, televisando de Miami uh, para el Congreso de NeuroInterventional Radiología de Madrid sobre la dirección de Luis Ibor López. Y tenemos mi co-host, Marco Antonio de Bolivia. Hola, Marco.
Buenos días, mi nombre es Marco Antonio, les hablo desde Cochabamba, Bolivia. Muchas gracias por la invitación para participar en este congreso.
Sí, sí, es 3:30 en Bolivia.
Exacto.
Marco
Aquí.
tiene mucha dedicación. Ok, espera un minuto. Sí, estamos casi listos a empezar. Y sabes que no puedo ver la cámara, no, no puedo ver la cámara. Sí, estamos grabando, hablando inglés. No está conectado. No tengo cámara de sitio. Podemos editar. Oh boy. Hello. Okay. No sé qué pasó. Estoy esperando para... ¿Tú no tienes problemas entrando o tienes problemas? Marco, ¿tú tienes problemas entrando o no?
El primer link que me envió no podía porque me decía que no
Ah,
estaba.
sí, se acabó. Es un link diferente.
Sí, pero en el segundo no, ningún problema.
Ok.
Sí.
Oh, man. Ok, la gente está mandando nosotros hablando. Ok. We are waiting to televise from Madrid. We're setting up. Okay, finalmente. Okay. Tenemos. Okay.
Favorite 10 days.
Okay.
Really no more an issue.
Okay. No tenemos cámara, pero poco a poco. Aquí está.
Within the market capital. We did upload averting treatments in 600 saccular aneurysms, 461 with P64, 122 pipeline, 9 combinations and 8 failed attempts, 270 fusiform aneurysms, 5 dissections. The flood averts are actually in Germany reimbursed for dissection. So we write dissecting aneurysm. That's a code where you get full reimbursement for using flood averts, which is I think different from some other countries. At least flood averts for CC fistulas in all kinds of acute occlusions, maybe due to dissection or other reasons. And in a few stroke cases, we used when we were unable to get thrombus out of the internal corridor, we used the flood averts simply to fixate the thrombus in the ICA, which is non-reimbursed, by the way. The analysis was done in retrospect, of course, and we did it per procedure. So the counting was kind of a counting oriented on the single procedure, and any complication of potentially significantly occurred in 12% of the P64 procedures and 16% of the pipeline procedures and in 21% of the combined cases. These numbers are not kind of real safety margin numbers. So as I said, we started with pipeline, so the 16% complication rate with pipeline related to our learning curve, and 12% of P64 doesn't necessarily say that P64 is safer than pipeline. It's just that when we started with P64, we had way more experience than was the case when we started with pipeline in September 2009. And the 21% of the combined cases simply reflects that these are more complex, more dangerous cases. We try to differentiate things happening during the procedure the first
Cuando lo grababa pude subirlo
the long-term course of these patients.
máximo.
So the event rate during procedure was 5% for P64 and 6% for pipeline, quite similar numbers. During the first month, 4 and 6%, and in the long-term follow-up, 3 and 5%. The far majority of this case, and I show you a series of examples, the far majority of these cases are ischemic events. So the rate of real hemorrhagic complications is quite rare. The issue with flow diversion is not really hemorrhagic issue. It's more or less, I would say 90% ischemic products. Of overall morbidity and mortality, the permanent morbidity, serious morbidity rate is 2.3%. 19 patients experience a permanent and neurological morbidity related to the flow diversion treatment, and the mortality is 1.9%, 16 out of 830. We started with a traumatic case. This was actually the first pipeline case we did in September. This was a large supracoroidal aneurysm. She was referred from a neurosurgeon. He had tried to operate on the aneurysm and couldn't flip it. We coiled the aneurysm and put a pipeline over the neck of the aneurysm. This was technically very special. There was nothing special. It was just putting coils and putting fluid with it. And we had actually no real experience at this time, so we didn't know anything about the post-medication, so we just put the patient on heparin as long as she was lying in her bed, and we put her on dural antiplatelets. And we were quite pleased by the result. This was 4 days later. She came back, this was on a Saturday. This was the first day without heparin, and she had a massive intraventricular hemorrhage. We did an angiogram, and at this point, no heparin, no steroids on board. You could see this little contrast stain coming from the dome of the aneurysm. That was the point where the aneurysm had ruptured, and the patient eventually died from this rupture. Many of these complications we encountered are a combination of, I would say, bad luck, operators, failures, or mistakes. This is a typical complication of this kind. It's a patient came with a symptomatic convergence carotid artery aneurysm with a CC fistula from aneurysm to the convergence sinus. The treatment was literally straightforward. It's P64 put in the internal carotid artery. The patient was discharged and came back 2 days later with the emboli. He had a dissection related to the guide catheter and severe dissection of the internal carotid artery. We put a stent over the dissection, but meanwhile, the patient experienced a massive stroke on his dependent hemisphere, for which he died. This is another surprising case. The patient came for a megadolia ectatic basilar artery, which was symptomatic. She had a progressive tetraparesis. We treated her with flow diverters, which was technically easy. When we finished the procedure, we were in a kind of a hurry because we were becoming a series of emergency cases coming at the same moment. So we were probably too quick in closing the puncture side of the groin. From the puncture side needed blood transfusion, and apparently the blood transfusion, the transfusion of blood without aspirin and Plavix in this blood instantaneously caused a transformation in the flow diverters and in the basilar artery. This is the image before the hepatic basilar artery. These are the, you see them, it's really dark, yes. Flow diverters in the basilar artery. immediately after. Then she hemorrhaged and came back from the operation theater. She didn't actually wake up from the operation of her groin hematoma. She was brought back to the industry and had this massive ischemia of the cerebellum, and apparently the basilar artery was occluded. This is about 2 hours after putting the blood diverters into the basilar artery and giving her the blood from cells without inhibiting their function. The basilar arteries apparently occluded. We did aspiration thrombectomy, which was technically easy, but it was simply too late. And when we came and did the thrombectomy, there was already established ischemic damage of the brainstem and cerebellum. This is the image before. This is after. Technically straightforward, very easy thrombectomy from the basilar artery. I think it's a matter of minutes. If you're not really there when it happens, you have very little chances to rescue the patient. After the thrombectomy, she bled into the posterior fossa and died. Collateral damage. This was a man with a large cavernous aneurysm. He came with severe headache. He had cranial nerve palsy as well, but his main personal problem was severe headache. We treated the aneurysm, and I gave him a clear schedule how to fail on the steroids, and he kind of got used to taking the steroids. Whenever he felt bad or had headache or something, he just took steroids by himself, to the point when he developed severe immune deficiency and died from pneumonia. So this is the aneurysm, easy treatment, coils and flow diversion, no big deal, and he just died from kind of incidental deficiency induced by the steroids. When aggregation may happen if the patient is taking the Plavix and the fractionators generally have a tendency to replace Plavix by clopidogrel. And the issue is that this generic clopidogrel is not inefficient. It has a completely different acting profile. So the patient can be under-inhibited, over-inhibited. You don't know. It's kind of giving a different drug. It has the same name. It is clopidogrel, but the efficiency is completely on an individual basis. It's completely unpredictable. Patient being just right, and Plavix can be completely over or under-inhibited if it's replaced by the generic drug. This was a lady with this dissecting aneurysm of the basilar trunk. Pipeline P64 in place, everything's fine. She went home, and the same week the fractionator replaced the Plavix we had given her the generic clopidogrel, and this is 1 day after, 4 weeks after, she slowly had TIAs and they didn't react. They said, this comes from the blood diverter, and they didn't need a test or send her for any MRI imaging. So she had recurrent TIAs, had this one-time infarct. When she came back, she was literally uninhibited from despite she was under 75 milligrams of clopidogrel, and the aneurysm fortunately was gone. And surprisingly, she recovered from blood pattern from 3 to 1, which was just like it. She had a real severe one-time infarct related to the fact that she was uninhibited for Plavix or clopidogrel for a couple of weeks. Those are the monsters. When we started, we were kind of hypnotized by using pipeline. We just couldn't stop, so to say. And this is one of the cases, symptomatic megadotic ectatic basilar artery. And we started putting pipeline after pipeline. We just liked it, and it was a fantastic technique putting the pipelines, and we ended up with 18 pipelines, one telescoping, one inside the other. And we felt quite good. We liked the picture, we liked the procedure, and it looked great. And we look, this is the 1st of July, the 2nd of July. The image looked fantastic. The ectatic artery was literally reconstructed. Unfortunately, we had significantly changed or completely changed the hemodynamics of the brainstem, and there is no more flow from the other side. We failed to early on obliterate the left vertebral artery, which was only one of many mistakes in this case. And these 18 pipelines induced a massive and eventually fatal one-time infarct. This was one of the first patients we did in this pipeline trial. We used only pipelines and put one inside the other. It was growing, as you see here, the aneurysm growing between 2006 and 2013, so it was real indication to treat the patient. And we telescope pipelines, not 18 in that case, I think it was only 4. August 2013, 4 pipelines, one inside the other in 2013. And this is the separation. So at this point, it was just an ectatic basilar artery. And the pipelines were shortened and separated. It was kind of a inverted hemodynamic effect, blowing out the aneurysm and creating this fall of the basilar artery. The patient came because it was very symptomatic. It was unable to swallow and it was rapidly progressive spastic. We closed the gap and reconstructed the basilar artery, and the patient fortunately recovered completely. So the mass effect on the brainstem was completely reversible, and the patient is still doing well. This is later on. Closing the gap, closing the other vertebral artery there. Yes, we know they really do need urine aggregation, and this was he was a guy from France. He came for treatment to Germany. I spoke to him in German and French, used the translator and explained everything to him. And this is before and after this series of dissecting atherosclerotic aneurysms of the basilar artery and the cerebral arteries. We were pleased with the result. We had a follow-up. And I explained that the majority of the aneurysms is gone away. It's obliterated from this mass reconstruction, and he completely misunderstood. He literally left the hospital, threw all medications away, understanding I'm cured. So he was just out of his mind, threw everything away, and died a day later just from having a basilar artery thrombosis. Similar story, large basilar artery. The widow of the patient said, you know, our source of beer is 600 meters away. He was able to walk 400 meters. So he went to the vascular surgeon for peripheral atherosclerotic disease. He went to the vascular surgeon and said, this is something for my legs. I want to walk 600 meters. And the vascular surgeon did operation on his lower legs and his peripheral atherosclerotic disease. We were quite pleased with the result. The vascular surgeon, without any reason, stopped the anti-aggregation. He said it's not really necessary, it's overdone. And he came back with thrombosis of the basilar artery. And eventually died from this, and had this massive stroke for no reason. And it's maybe a good idea to put a tattoo on the patient saying, please don't stop vascular clot. Continue, whatever it takes. We learned a lot about the interaction of drugs. This was a large aneurysm, basilar artery aneurysm with the ICA growing, rapidly growing. The ICA originating from the aneurysm sac. This is the origin of the right ICA. And this is within a few months. This is 24 millimeters, 27 millimeters from October 2014 to April 2015. This is before the procedure. You see the aneurysm sac and the ICA coming from the aneurysm sac, and the plan was to put a stent over the aneurysm, put a few coils, and go for fluid diversion. And this is the immediate result. A few points in the aneurysm. We quite like to put a few points because we learn that putting points just interrupts the circulation of blood in the aneurysm, so it simply accelerates the process of it enhances the process of blood evasion. Please, this is a discharge, 20th of April 2015, the prior of discharge, and this was the post-medication schedule we had given to the patient. We said you should take 100 aspirin daily in the morning, and you should take relief, and we give you monoambulites and everything, and you should take ibuprofen only in the evening. He had before that, he had a ventricular shunt that he was used to use ibuprofen because he had headache after the ventricular shunt. And the plan was taking aspirin in the morning and taking ibuprofen in the evening. And this is these are the multiplex tests after just after loading. We have dual anti-aggregation. This is after the treatment. We gave some integralin during the treatment, so we have kind of triple anti-aggregation, virus, aspirin, and integralin. And this is after ibuprofen. You see, we have ibuprofen. This is 18th and this is 24th of April. After the ibuprofen, there's no more action of the aspirin. The ibuprofen, he took ibuprofen against our advice in the morning together with the aspirin because he had severe headache, and the ibuprofen instantaneously antagonized the action of aspirin. He came back with this immediate thrombosis of the of the pleurovirus. We aspirated went for aspiration thrombectomy, which was again easy and successful, but just too late. It's the after the aspiration thrombectomy. And this is the fatal on-time cerebral heart. This is the key paper describing this relation. If you give aspirin and in the same moment, either and this is surprisingly good. This is 2014, 2015, and it's in thrombose. We see quite a number of instant stenosis. This was a lady, she had a subarachnoid hemorrhage, was operated for the subarachnoid hemorrhage, and she had an aneurysm here. You may see the clip here. And the neurosurgeon who operated on her said, I took the aneurysm, but the aneurysm didn't bleed. The bleeding was coming from the blister, and I couldn't clip the blister. So the blister aneurysm, which was the real source of her hemorrhage, was here. This is the clip on the innocent aneurysm, and this is the blood diverter for the ruptured blister. and this is 2013 and 2015, you see a significant instance stenosis. It was asymptomatic, just for the reason of showing the course. This is in the interval of 3 years before this intimate hyperplasia. We did nothing, just continued with the pure antiplatelets, and as you may see, the intimate hyperplasia resolved by itself. And we now understand that quite a difference from the regular stem leads in atherosclerotic disease. Putting floater may result in instant stenosis. It is most likely not real intimate hyperplasia. We had one case, I couldn't find the image, we had one case with this intimate hyperplasia, and layer of thrombus inside the floater, which may explain why it usually goes away by itself. So to summarize, unless you are working at level of Sierra, I think the complication rate is low, and we have very good safety profiles. And the far majority today are more or less ischemic issues. If we forget about incidents like vessel perforation or other stupid things, the main issue with floaters today is our ischemic problems, and I think within a year or two we can see real cold floater verdicts which may overcome this issue. Thank you very much. Luis, say something smart. We see, I would say, something like 15% of all kinds of incidents stenosis, and I don't remember a single case where the vessel occluded from this instance. It usually goes away. No matter how severe it is, it goes away for any reason.
15, 1-5. And 3 months or
between 3 and 9.
Between
3 and 9 months. You see at any point.
So you encounter on your 9-month control angio with rather sporadic fashion. I mean, asymptomatic.
Usually asymptomatic, and in the very beginning, another difference is when we saw any kind of instance in the pipeline, we were scared to put balloon and dilate pipelines. Now, since we know there is no reason to go for this kind of balloon dilatation, we don't do it with P64 and other differences. So I think, yeah, we don't do any job with the ambulance patients symptomatic, and we had not a single symptomatic patient. We did in a child with a combined P64 and pipeline case because we thought it may be difficult for parents to understand if one is symptomatic or not with this instance, and not severe instance. And we did no other treatment in P64 instance. My gut feeling is the frequency is probably a little higher than the pipeline.
Thank you.
Thank you so much for the presentation. Quick question. You mentioned on the fifth form basilar aneurysm, the whole basilar aneurysm, then if you have to go back, potentially use less devices, and maybe also take the condylovertebral artery. Now, I think that there is a discussion to be had, because in that case, when you have
weeks before we take the retrieval artery away. And I think the most critical point is that currently have to combine anti-aggregation with anticoagulation in these patients. So we see way less ischemic complications since we combine and pure anti-aggregation with giving direct anticoagulants. So usually with Pradaxa to these patients for 3 months in combination with pure anti-aggregants and have much better results.
Do you give planning semester for life for the patient treated in the anterior escalation?
We give, usually, if you use, let's say, 1 or 2 devices, we give dual platelets for 1 year and aspirin forever. If we have this mega construct, we give dual anti-aggregates forever.
Thank you your better medicine, but in our opinion, it's different, totally different, the arteriosclerotic aneurysm or the second aneurysm with another one. In our experience, I don't use the polyverter in this type of animals, and it's sometimes okay, because you are many complications. If you are the big service, you only analyze the vascular dissecting or vascular arteriosclerotic aneurysm. What is the complication of polyverter is very high. I prefer to start to use test occlusion of the vascular artery and have 7 patients, total occlusion of vascular artery is the first choice. And the second choice is we do a standard stem, soft stem, or no stem. Why? Because you have less radial faults in the wall and you have less complications in the evolution. I have one question is in acute complication after the chronic stent is the dissecting of arteriosclerosis. This acute complication is to secondary to mass effect to the brain stem or ischemic brain stem with the reason.
So coming back to the first argument, we had seen, I mean, we started, as everybody, we started with the regular stents, including Leo stents or any other kind of telescopic stents into these italic basilar arteries. And in the pharmacology case we followed, we didn't see a real impact of this kind of treatment on the course of the anesthesia. At least in our experience, I would say if you put telescoping stents, a significant number of these patients just continues to deteriorate and the aneurysm continue to grow. So if your goal is to interrupt the growth of these secondary components of the megadotic basilar artery, the goal is to interrupt the growing process. Just putting porous stents may fail. The acute complications and the far majority of cases we had seen with blood awareness are very skewed, such as obliteration of perforators to the brainstem. I remember 2 or 3 cases with rupture of the basilar artery fatal rupture of the pulsar artery with stents. And all these cases have been common that we kind of created flow diverting effect by putting numberless Leo stents in the pulsar artery and created the effect that is known today from large aneurysms treated with flow diverters, just having too much thrombus, digesting the aneurysm wall and creating the rupture.
You are, in your experience, you are more complication with a standard stent or probably the stent in this type of aneurysm?
No, I mean the flow diverter is sharper sword. If you use flow diverters, you have more effect and you have high risk. But if it works, the effect can be fantastic.
I think that another different solution, well, another evolution we can reach with the standard stent is because we use the very long stent, more than 50 centimeters, and you have the possibility to change the flow in the origin of the vertebra and then you go to very far.
Sure.
And this is change the flow and slowly and you are less complication.
Sure, the flow effect, the longer the stent, the more impact on the flow you may expect. The longer flow diverters, we try not to use long flow diverters for all kinds of twisting issues and stuff like that. So the use of long stents is certainly a good aspect.
What is your experience using P64 in acute phase of thoracic hemorrhage?
Yeah, we have not done so many acute analyses. All these analyses were done because they were either just unclippable or colleagues failed to clip the analysis. We did cases, none of these re-ruptured. And we had no serious issue. And it's pretty much the same equipment. We did only pipeline used for two dissecting aneurysms for the same result. So it's apparently surprisingly safe.
Late 1970s, but the term of blister introduced by Takashi in the late 80s. You're okay. That's better. Okay. Initial and most classic definition of the blister aneurysm connected to the internal carotid artery, but it is not anymore in that location. We are seeing blister aneurysm in every part of the intradural arteries, non-branching part of the segments of the arterial structures. When you look only the internal carotid artery aneurysm, it goes up to 6%. When you look whole intracranial aneurysm, is about 1%. And then around 2% in all ruptured aneurysm. Pathogenesis is unknown. There are speculations, atherosclerosis, hemodynamic stress related to the hypertension, and anyhow, any kind of cause which creates arterial dissection is a possible pathogenetic factors. When you look at the pathology of these aneurysms, it's mostly resemble the pseudoaneurysms. And histologically, there are lack of disruption of elastic laminas. That's why it's enlarging rapidly, and they are rebleeding frequently because of that fragile wall cannot prevent re-rupture. This group is the worst group. Everyone has a lot of complication. Intraoperative complications, post-operative follow-up complications. Regrowth rate is the worst one, comparing all kind of intracranial aneurysm because of that histopathological features. So, I want to start the old case is 1997. Shape aneurysm just on the anterior wall of the internal carotid artery. They sent the patient to us. This is almost a month later. Look at the morphology of that segment. Totally changed. That segment becomes fusiform. Also, the lower portion, posterior portion of the internal carotid artery affected. Even though at those years, we did our best with balloon remodeling and coiling. Look at that. Just a year later, that disease portion includes whole circumferences of the artery. It becomes a fusiform enlarging aneurysm. Whenever you saw the case, of course, it is not ruptured and passed away. You are seeing different morphology of this group. That's why some group try to classify the morphological aspect of the blister aneurysm. Of course, they started little blister shape and then goes to the fusiform enlargement. It is understandable theoretically because of the disruption of the elastic laminas and the weakening of the vessels can create fusiform nature. Most of the time, we are seeing those cases in acute stage. As we know, that simple coiling is not enough because we put the bioactive materials in it, with balloon remodeling, without balloon remodeling, it does not work. We will have re-rupture, we will have bad results. So especially for those groups, fusiform, very wide neck, tent shape aneurysm, we started to use stents. And then we decided, we started to discuss about our anti-thrombotic protocols in acute stage by using stent. But anyhow, it is better to use a stent to prevent something. Like this, there are different techniques of it. This is non-flow diverter stenting coiling technique. You are putting your coils and deploying your stent afterwards. It may prevent your intraoperative rupture. Because don't forget that aneurysms has no wall. So due to the radial force of the stent, you are pushing the coils and then have a chance to occlude that fusiform portion around the stent. And like this. And this is immediately after. And one crucial thing in those groups, every group is agreed upon. So it is better to do a control run, early control run, to see what's going on. Because when you look to meta-analysis of the blister aneurysm, the articles, that stent-assisted coiling, it has the worst outcome comparing the other endovascular technique. One of the best may be the parent artery occlusion, but that parent artery occlusion also has some problem because of that acute stage. You may have a good parent artery occlusion with a good collateral flow. Due to the vasospasm, you may have infarction, and in the articles concentrated on it, also had bad results. So when we started to discuss about our bad results with stent-assisted coiling, we should start to discuss about parent artery occlusion results in the acute stage. In the non-acute stage, parent artery occlusion, of course, it is so clean, and you can foresee there will be no vasospasm or infarction. So in those groups, if we already decided to control frequently, we should avoid to give extra X-rays to the patient. That's why this is our strategy. Whenever possible, we are doing a contrast-enhanced MR angiography for follow-ups. And so you can, if you have a good MRI and good protocol, you may see there is no feeling around the stent, even though you have a stent metal artifact there. One problem coming from that contrast, because as you know, and as we know, the contrast accumulation of the brain is another problem. So you need to choose one of the follow-up protocols for your case. It is so easy that, okay, do a control angiogram every 3 months. There is a risk also, X-ray and angiogram risk. So everyone has different protocols on that manner. There is no fixed protocol in the literatures. Especially with diffuse subarachnoid hemorrhage, most of them are missing because of the less efficient protocols in the acute stage. Most of them, that tiny aneurysm are missing because of they're just doing MR angiography, they're just doing CT angiography, and they're letting the patient wait for a second follow-up. So it is mandatory to do a groin puncture angiography for all subarachnoid hemorrhage. It is the message to you. Another case, ruptured, they wait later, the patient came to us. This is a kind of classical appearance of that blister aneurysm, and it also, because it is away from the vasospasm period, the 1 month later, you see the stenosis just proximal to the aneurysm. It is more, we are thinking more prone to there is a dissection because of that intramural thickening and the reactions there. So in that non-acute stage, the flow diverter is a good tool in that tent shape, very wide neck, the aneurysm treatment. And we did it, and this is 3 months follow-up. Aneurysm totally disappeared. It is interesting, for the flow diverter group, we are really having a nice early occlusion of any kind of dissecting aneurysm and also the blister aneurysm. It is the observation. This is the 6 month follow-up. Another case, the old one, 1998. I followed this case. It's a ruptured case. The surgeon did a great job, clipped and wrapped, both of them. Because after clipping, they realized that there is no wall of that case, and they start to wrap. This is not a standard, the protocol of the surgeon. They only just clip. But the surgeon is better to understand that weakness of the wall than us. So it is 5-year follow-up. See the enlargement of that cleft segment. That's it, no symptoms. This is 9-year follow-up of this particular case. That enlargement portion is growing. And this is 14 years of follow-up. She came to me because of a headache, different headache. And I decided to do an angiogram. This is the angiogram 3D. Look at the clip. Look at that circular, the deformation of that fusiform segment. And at those time, I decided to put the flow diverter to that case. And this is the flow diverter. And this is a year follow-up. Look at the clip, turn back to its original position, no gap between the clip and the stent, and the proper reconstruction of the artery. Of course, we need to look at 10 years after of this group. What will happen? Because the transition zone is still unknown. So the last year, that Arizona group, Spessler group, suggested to use this protocol for the internal carotid artery blister aneurysm. What they're doing, they are trying to do their best in the acute stage. They are clipping and wrapping. And after acute stage in the vasospasm period, they are taking the patient again and doing a flow diverter treatment. Because they're in the United States, they're using pipeline. And so this is the suggested plan of that internal carotid artery blister. But what will happen for the other blister aneurysm, which cannot be clipped and wrapped? Another case, the marathon runner, after 15 kilometers, had a headache, still continued to run, and then their friends take her to the hospital, and then the radiology shows that kind of aneurysm on the same segment. Even immediately after stenting, you may see some change of the group. This is our observation. Look at that. It is not anymore that previous aneurysm, and this is only 1 month later. Early reconstruction of the artery is suggestive of dissections in general. So when you look at meta-analysis, this is the last year one, and then when you looked at the technique surgery is doing, and what we are doing is here, that dotted line, that there is a tendency to use stent, of course, not single coiling. And also there is a tendency to use in combination with flow diverter and the coil, because we didn't feel safe in this group. We are trying to do best from morphological point of view. So let me show some other blister aneurysm which are not in the internal carotid artery. This male had a facial paralysis and sudden onset. Look at that tiny dot here, perimesencephalic. The MRI shows that kind of hyperintensity on the same location. When you look at the non-contrast T1 weighted images, it is hyperintense, suggestive of hemorrhage. And this is contrast enhanced imaging that those getting seen better on some vessel. What is this? While waiting, this is an MR angiography, shows something here, but not so obvious. And nothing on the thalamus. Why I'm showing thalamus to you? Because just 2 days later, in the hospital, she created a sudden hemihypoesthesia, new MRI showing a new infarct on the left thalamic region, which is actually the territory of the anterior thalamic artery, that artery arising from the posterior communicating artery. And the right side, no P1, but the fetal type posterior communicating artery. And this is it. It is so obvious that that kind of dissecting blister type of aneurysm can occlude that anterior thalamic artery orifice from theoretical point of view. You can combine all the things together. So we haven't got tiny flow diverter at those time. While we are waiting that tiny silk from France, this is a month later, it started to heal itself without touching. This is a year follow-up. The patient is lucky. Another case, again, the same infarction. I already published this. That's anterior thalamic artery infarction with the dissecting aneurysm of isolated posterior communicating artery. The same infarction and the same hematoma and the same aneurysm on the posterior communicating artery. Look at that. Again, I decided to occlude the posterior communicating artery. When I got the patient, I realized that the posterior communicating artery occluded by itself. Not always. This is a 2.5-year follow-up of this case. Another case, this is ruptured. This is the saccular component. Again, the aneurysm, look at the junction of the posterior communicating artery is clear. Look at that. Again, the same infarction. And then you can coil it, you can occlude it. This is not the location you can wrap it, actually. So when you look to perimesencephalic rupture, supraarachnoid hemorrhage, there is numbers written in the literatures that is 5 to 10% of blister aneurysm. Are we really seeing those aneurysm? Like this is an obvious rupture. When you do a regular angiogram, you're all missing that tiny blister aneurysm, which is arising from posterior part of the basilar tip. This is the flow diverter treatment of this case, and this is a year follow-up and eradication of that blister. Of course, we can discuss the potential complication of the basilar tip flow diverter treatment. Another case, rupture. When you see the regular, well done, the angiogram, you're not seeing any. You need to go in details with 3D or flat panel detector CT angiogram. This is the blister aneurysm there. Again, the same treatment, one month later, it disappeared. When you look at the MR angiography, is nothing. 3D showing nothing. Case you should follow very frequently. I don't believe that protocol, if it is negative, especially MR angiography is negative, we need to wait 6 weeks or 3 weeks. You better do it very early, even in the same week. This is a week later, the same case. It's the coiling. 3 months later, look at that regrowth. Also the enlargement of the superior cerebral artery because of the dissecting nature. And then the recoil and the flow diverter is getting better, still some feeling, but she's in a good shape. Another case, pregnant, ruptured, MR angiography was normal. Should we wait? No. We should do an angiogram. Okay, we did an angiogram, it looks normal. Is it okay? Let's look at the tiny details of that flat panel detector CT. There is something here different than the other perforating arteries. When you look in details, actually the aneurysm is on the mesencephalic perforators, not on the basilar tip. So what would you do right now? To go in the mesencephalic perforator and occlude so? Actually, we wait. What will happen, and then 1 month later it disappears spontaneously. So we should also take care of the perforating arteries for that tiny blister-like aneurysm. And we should look and follow up frequently. Like this is a ruptured 44-year-old lady. Because of that enlargement, and we decided to put 2 neuroform in, I think, 2003, yeah. 2003. we were believing that the two telescopic stenting preventing enlarging. Look at that. This is the post-stenting. No change, of course. This is just at the November in the same year. Look at that. In April, something happening here. Just simple fusiform enlargement turned out to be a kind of circular wide neck aneurysm. And at those time, we coil it with balloon remodeling technique. This is May 2005, looks good. This is the 2015, 10 years later, still looks good. So we should follow the patient frequently in the follow-up period. And in those mid-basilar group, I don't want to go in details because Jiwan will describe our mentality in Cerrah Pasha on posterior fossa flow diverter treatment. And thank you for your attention.
So maybe I missed, but in the acute phase today, what is your recommendation in terms of the antiplatelet treatment and placement of flow diverter? Do you do the flow diverter first, then give antiplatelets, or you give antiplatelets before you do the treatment? And another point, we tend to always have a balloon available, ready to go when we're doing the flow diverter in acute phase. Bleeding happens to have a tamponade with a balloon. So I don't know if you think it's a good idea, but I think it's a good recommendation to have that. And the third question is, do you always coil on the acute phase, or you just place flow diverter?
Okay, let's start for balloon. It's regular routine things. We are having balloon in every aneurysm case. Not on the blister, it is ready in our hands. Yeah, it is a good point to have balloon to protect the patient in acute stage. For the second question, for the third question, actually, if it is coilable in the acute phase, I prefer to put some material in that enlarged portion to facilitate more thrombosis. But time to time, it is impossible to put the coils. How can you put the coils in a tiny posterior communicating artery, for example? Or that the basilar tip blister aneurysm, it is impossible to do so. It depends on the morphology of the aneurysm. That blisters not stay in that blister morphology. It is enlarging quickly and rapidly. If you have a chance to have a space to put coil, you can do it. And that putting the coil in the parent artery, squeezing the coil technique is kind of really very useful on that group. For preparation, we are actually not giving anti-aggregant at the beginning because we thought that the wading in the acute stage without touching the patient is more risky than doing the case. First. So we are treating the patient in acute stage. First thing first. And then we are putting nasogastric and then preparing our anti-aggregants. Most frequently, that the quick, the responsive anti-aggregant drug is choosing for this, maybe FENT, for example. And then after deploying the stent, we are giving from nasogastric. In that gap, 2 or 3 hours, we are supporting the patient with IV anti-aggregant like tirofiban is Agrestat in Turkey and Europe. This is the strategy of us.
Thank you for your very interesting revision. One comment. The blister aneurysm or dissecting aneurysm is very problematic pathology because 75% rebleeding in the first 2 or 3 weeks. This is the problem. And your revision with the surgery and grabbing of the aneurysm maybe is interesting, but I think it's very difficult. The imaging of a magnetic resonance or CT scanner, you are the possibility sometimes in the special localization, you are possibility to know maybe inside the vessel you are the blister aneurysm. Very, very interesting. And my question is, why many subarachnoidal perimesencephalic hemorrhagic is benign? No, it's not benign. Maybe you are the. It's not benign pathology. Maybe it's the blister aneurysm in this patient. And do you think to prevent the patient, why not to use one stent, no, fraud diverter, whatever you want, to prevent the possibility develop of aneurysm or rebleeding? The question is very, 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 very important because it's normally the young patient, is not the old patient. Is the patient have the vessel is good vessel in totally branch of the brain, but have acute hemorrhagic in special localization, and you analyze with the standard angio, you don't see the aneurysm. You need the 3D reconstruction, you need the vasco imaging or vasc imaging, or you need the magnetic. I think it's, the analysis of this pathology is very, very difficult, but sometimes you are sure, or you are the probability this localization have aneurysm. Why not to put one preventive stent?
You know, not for every aneurysm, but if it is possible, the cover stent mentality is the best in my mind for this group. If you can able to put the kind of cover stent, now the new cover stent is coming and new mentalities are coming. But of course, that cover stent cannot deploy that basilar tube and other perforating rich areas. But in certain group, to get rid of flow inside that non-wall enlargement is the best way of treatment. But it is interesting that the flow diverters in combination or not in combination with coils has a little bit more better result than the other stent assistant coiling techniques. So endovascularly, we should also think to work with our surgeons to combine the treatment in the acute stage with wrapping, because clipping for those aneurysms is not easy. Their intraoperative rupture rate is really very high in the surgical group. It is something 40–50% intraoperative rupture because of that tiny aneurysm. The wrapping is something, but it is better not to trust the wrap, as I show you in an example.
Your experience with cover stent? Your experience? Your experience with cover stent?
We used a lot in the past that Joe stent, but those are the proximal, most of them proximal aneurysm. We had some case in dissecting group. That's why we created a scaffolding cover stent technique, stent era at that time. And then it was a real hemodynamic treatment in that dissecting group. We had experience so. But nowadays we haven't got good cover stent in our hands.
I think the other question then, this is, I don't know the answer to this, but if you cannot place coils, would you be inclined to use only one flow diverter or multiple flow diverters? Because the argument is that if you have only one flow diverter, no coils, because you can't place the coils, is that enough to protect? And I think
it is, because the second telescopic flow diverter, even it is the 38 wires, just reducing the flow only 10 to 8% additionally. It is no. Even though you created a crowded metal in front of the neck, you're not getting a huge hemodynamic effect just because of it. As the previous speaker Hans mentioned about that, the gap between stent and the vessel wall is such important. If we are thinking and knowing that that group is a dissecting group, we should adapt our stent properly to the intima, because our goal is not the reducing the hemodynamic. Our goal is the creating an intimal reactions and thrombosis over the neck. This is different than sacral aneurysm mentality.
Do you have any experience or idea if the pipeline shield, the coated pipeline version, if this works with mono anti-aggregation, aspirin only, or Plavix only?
I don't have any experience, so, but you know, it is a nice point. There are some groups, especially, you know, in Shanghai, we invited the physicians from Amman. They are not giving anti-aggregant, just giving heparin in that pipe shield group. They have good results, but I don't know. Do you have any idea, Dimitris? You are working on it?
Nadi, I publicate my experience with patient with subarachnoid hemorrhage without aneurysm. And we see many, 24 patients, and all patients have fenestration of anterior communicated artery and needle. We have patients with aneurysm and fenestration. And what do you think? It is not small. It's not small prepontine hemorrhage. It's very massive subarachnoid hemorrhage, and no aneurysm, no evacuation, small 1 millimeter, no nothing, but only fenestration. What do you think? What do in this situation? Disconnection of anterior communicated artery, treatment, analyze, no, nothing. What do you think?
You know, at the beginning, Gazi Yaşargil and his students in Turkey are mentioning us that when they are operating in certain aneurysm, they're also seeing such blister and the aneurysm on other segments. And they had a tendency to clip those the enlargements, that tiny enlargement, and we are criticizing them. Why you are doing so? Actually, when you look at the surgical opinion on that tiny blister group in the literatures, you can find a lot of ideas on it. Maybe they found those group the pre-ruptured period by treating with the other sacral aneurysm. So first of all, we should enhance our diagnostic tools and mentality. Just only talking about conventional angiogram. We should talk about 3D images and the best images which is given by our flat panel technology in the angio system. Maybe we can find more blister aneurysm in a non-ruptured period. That you're right. You are mentioning that fenestration combination with tiny aneurysm in the anterior communicating artery, and then the other colleagues also finding the same things nowadays. Yeah.
I disconnect of anterior communicated artery with fenestration,
kind of
but I think this
occlusion, yeah.
border for critics.
We have done a study about fenestrations in cerebral arteries, and we did 3D angiograms in a lot of patients, and we found that in the anterior communicating artery complex, in about 30 to 40% of all patients, you can find fenestrations. So they are very, very common. If you look for them, you can find them. So there's no relation to any hemorrhage or whatever. It's very common to have a fenestration.
Right. Thank you.
Oh, no. I have to go to the beginning. Go to the beginning. Okay. Good morning. My name is Willem-Jan van Rooij. I'm from Holland. And I thank Luis very much to invite me to beautiful Madrid and to share our experiences with the treatment of ruptured aneurysms with the web. Well, how did we start with the web? Well, we had very poor results with stents and coils in ruptured aneurysms. We had too many thromboembolic complications, and we had also too many early rebleeds. So we were looking for an alternative for stents in ruptured aneurysms. And that's how we came to the web. And we started in February 2015 with the web for unruptured wide-necked aneurysms to replace stents. And that is the indication where it was developed for. And our first results were very good. This is a wide-necked ACOM aneurysm, and we treat it with the web. It's an unruptured aneurysm. And so no stents. The immediate result, and this is the result after 3 months with a perfect occlusion of the aneurysm. Another early case, a wide-necked basilar tip aneurysm treated with the web, no stent, but with a very good result after 3 months follow-up. Another challenging case, an incidental, small, very wide-necked basilar tip aneurysm, also treated with the web, no stent, and with a very good result at 3 months follow-up. So we were impressed by our first results with the web, and we decided to become more familiar with the web technique. So we gradually expanded the indication to all aneurysms suitable for the web. So not only unruptured aneurysms with a wide neck, but also ruptured aneurysms and also aneurysms with a small neck. Like this one, a small neck carotid tip aneurysm, of course easy to coil, but it's also very easy for the web. It's a spherical aneurysm, and we put in the spherical web. It's a perfect fit. This is after detachment. And here you see the 3 months follow-up with a complete occlusion and with an intact fenestration of the M1. Ruptured aneurysms. This is an example. The most aneurysms we treat are anterior communicating artery aneurysms. This has a relatively wide neck. And here the via 21 is entering the aneurysm. And then the web is coming. And then it's slowly deployed in the aneurysm, and we try to put it to seal the neck. And now it's completely deployed, and then it's detached. And you see the position of the web inside the aneurysm. It nicely seals the neck of the aneurysm. And this is the 3 months follow-up complete occlusion. And well, most ruptured ACOM aneurysms are very small, but with the web it is even possible to treat very small ACOM aneurysms. This one is just 3 to 4 millimeters large, and even in such a small aneurysm it is possible to place a web. This is of course the smallest web, the SLS4, so 4 millimeter spherical web, and now it's detached. It's a perfect match, fit in the aneurysm. And this is the 3 months follow-up, a complete occlusion. Another example, a young woman with a ruptured carotid tip aneurysm with a small neck, asymmetrical aneurysm. The VA21 is inside the aneurysm, and then the web is coming, and the idea is to seal off the neck of the aneurysm. And Now the web is coming. This video is a little bit accelerated, of course, because otherwise it's getting boring. And an immediate complete occlusion of this small aneurysm. Sometimes it takes, the aneurysm is still filling, or the web is still filling, but then if you wait for 10 minutes, and mostly the aneurysm is closed. A ruptured posterior communicating artery aneurysm, the web doesn't always have to fit precisely inside the aneurysm. This is the kind of a mushroom aneurysm, and here we deploy the web first in the aneurysm lumen and then pull it in the neck just to try to occlude the neck of the aneurysm. So now the web is deployed, but it is too small for the aneurysm, so we pull it in the neck. And we hope that the neck will be occluded, and as you can see, well, now it's detached. Now it's detached, and you can see with the control run that it's immediate occlusion of the whole aneurysm. MCA aneurysms, we also treat MCA aneurysms, of course. This is a old lady with a ruptured small MCA aneurysm with a relatively wide neck, and M2 coming from the base. And here the web is inside the aneurysm, and after 3 months, complete occlusion with preservation of the M2. So from February 2015 to October 2016, we treated 132 ruptured aneurysms by endovascular techniques, and 77 of those were treated by the web, which is 58%. Now this proportion has risen to almost 75%. And in these ruptured aneurysms, we did not use stents, no balloons, and no anticoagulation. These patients were treated within 24 hours after admission, so most of them on the day 0 or day 1. And we treated, in fact, all patients also in poor clinical condition, so 20 of the 77 were in poor clinical grade, but we still treated them. The location of the 77 ruptured aneurysms that we treated with the web is displayed in this graph. Most of them were anterior communicating artery aneurysms, PCOMs, and MCAs, and only a few in the posterior circulation. But in our practice, more than 80% of all aneurysms we do are ruptured, and most ruptured aneurysms are small ACOMs. These are the webs we used in the 77 aneurysms, and as you can see, almost half of the webs we used were the smallest available size, 4 millimeter, and most of them were the spherical SLS. And we used a few in the 5, 6, 7 millimeter range. These still go through a via 21, and only a few 8 and 9 millimeters, they have to go to a via 27, which is quite a thick catheter. And we did not use the largest webs because they go to the 33. Our follow-up protocol is angiography at 3 months in surviving patients and MRA at 6 and 18 months. And with follow-up, there's one feature unique for the web, and that is central recess filling. Mostly in larger webs, this was a ruptured PCOM aneurysm, and as you can see on the follow-up, there's some distortion of the web with, and then you can see the filling of the central recess, but it is still considered complete occlusion. We had also neck remnants at follow-up, for example, in this pericallosal artery aneurysm, but we deliberately left the neck open to give room to the A3 coming off the base of the aneurysm. And this is the only patient where we did an intentional partial occlusion. It was an old lady in a very poor clinical condition with a ruptured pericallosal artery aneurysm. And the web was in fact too small, but we said, okay, we covered the fundus of the aneurysm, and then we will wait if she will see if she will recover. And surprisingly, she did. And this aneurysm was clipped after 3 months. And this is the only aneurysm remnant we had in the follow-up and the only retreatment. We had angiographic follow-up in 56 of the 77 patients. 14 died during admission, and 7 has follow-up planned. So we had 1 partial treatment, the case I just showed you, followed by clipping. 8 had a neck remnant, 2 had a proximal recess filling. So we had complete occlusion in 84% and adequate occlusion in 98%. These are all, the neck remnants are included in the adequate occlusion as well. So we had a very good anatomical result. But you have to know these are very small aneurysms, and in general, the results in small aneurysms are much better than in larger aneurysms. Of course, we had complications. We had thromboembolic complications, and we had 1 rupture. This is a thromboembolic complication, the ruptured wide-necked MCA aneurysm. The web placement, we were very pleased with the result, the complete occlusion of this aneurysm. And but a few hours later, she became hemiplegic, and we took her back on the angio suite. And then you see the thrombus around the web. We managed to take the thrombus out and put the patient on the tirofiban. And she made a complete recovery. This is after 3 months. You see the aneurysm is still completely occluded with some filling of the proximal recess of the web, but she had no infarctions from this thromboembolic complications, and she was in a good clinical condition. Another thromboembolic event in this patient with a ruptured basilar tip aneurysm that we treated with coils, and we sealed the neck with the web. During the procedure, there was a thrombus in the right PCA, and which we managed to get out with thrombosuction, and the patient had no deficit, and as you can see on the diffusion MR, only a very, very small infarction. This is the only patient that eventually died. This is an old lady, poor clinical condition from a ruptured posterior communicating artery aneurysm. And as you can see, immediate after web placement, there is a thrombus in the MCA, which was present before the placement of the web. And we tried to get it out, but we didn't succeed. And this patient developed a MCA infarction, and she finally died. So we classified this as a procedural mortality. We had 1 procedural rupture without clinical consequence, and that is this case. And the only possibility to rupture with the web is in the beginning, when the web is not yet deployed, which comes here. You see there's a puncture of the web through the aneurysm wall. We deployed the web in the neck of the aneurysm to seal the neck, and we make a control run, and as you can see, there's an extravasation of contrast. And we waited a few minutes, and this is the results after a few minutes. And this is after 10 minutes, complete occlusion of the aneurysm, and there was no hemorrhage. And the patient was completely asymptomatic. In total, we had 6 complications. We had 5 thromboembolic events, 2 with clinical deterioration, 2 MRS 3 and 6, so 1 patient died. We had 1 procedural rupture without clinical consequences. So the permanent morbid mortality was 2.6%, which is acceptable. And we had clinical follow-up of all the 77 patients. Most of them were independent. 3 had a moderate disability. 1 is in a nursing home, and 14 patients died during admission on the sequelae of the subarachnoid hemorrhage. So our preliminary conclusions are that the web is safe and effective for unruptured or for ruptured aneurysms, and it eliminates or reduces the need for stents and balloons, and antiplatelet medication is not necessary, which is a very important issue in patients with ruptured aneurysms. So in our practice, the web has become the first choice in the treatment of all aneurysms. Thank you for your attention.
Thank you, Doctor, for your presentation. You show beautiful deployment at first of the web device and also complication related to the deployment. My question is why we don't want to antipallet patient with ruptured aneurysm. We can put in the first time the end part of the aneurysm, wait 1, 2, or 3 days with antiaggregation, and then put the stent, or do with balloon with heparin or with antipallet medication and without embolic complication. Why we have to use web to eliminate antipallet medication in ruptured aneurysm?
Sorry, I couldn't hear your question. Could you give me one sentence?
The objective of the web device is to avoid antipallet medication or anticoagulation in ruptured aneurysm. No? How to do that? We can put coils inside the aneurysm rupture, protect the end of the aneurysm, wait 1, 2, 3 days, put medication with the end of the aneurysm protected with coils, and then put the stent if we want to end of coiling the aneurysm. Why we have to use web device?
Yeah, there are many ways leading to Rome, and yeah, what you say is a strategy, but I think it is more simple to use the web, and if you, of course, you can also only use the web for wide-necked aneurysm instead of stents, and for small-necked aneurysms you can coil. Yeah, it's a matter of taste, I think, and in our experience, is the use of the web is a very straightforward technique. It is very simple, and it's also very quick. And sometimes we treat an aneurysm in 10 minutes, and it's amazingly quick. And so in our opinion, that is a advantage, and that's why we keep on doing it. But of course, what you say, there are many strategies to treat ruptured aneurysms. This is one.
I have 2 questions. My question first is of proximal part of web, so it's tail in parent vessel. It's without underplate treatment, it's not danger for microembolic complication. It's one question. And the second, web is very strong device. Treatment of rupture aneurysm, I think it's very dangerous, but for me, put in coil, it's danger, and web, it's very, very dangerous for treatment of rupture aneurysm.
Well, I just showed you that it's not dangerous in ruptured aneurysms. But your first question is the proximal marker of the web. If it protrudes in the parent vessel, that is no problem. We have never seen any problems with that. Even if part of the web is protruding inside the parent vessel, it is not a problem. We have not seen thromboembolic complications later on, except in the one patient I showed you with the wide-necked MCA aneurysm.
Thank you for your talk. And the most impressive slide for me was the one that you had the hemorrhage and you were able to stop with the web. And Can you share with us what is the technique that you use if you notice that there is extravasation? I know that this is a very one-on-one case there, but what do you recommend to do? Do you bring the device, if it's not deployed yet, would you bring it pull towards the neck? What is the technique that you do? With coiling, we tend to deploy the coil outside and inside of the aneurysm, but with a web, what would be your recommendation?
Yeah, well, I've experience of one.
Yeah.
And in this case, yeah, we deployed immediately the web, and this aneurysm had a relatively small neck, so it was possible to seal the neck with the web. But of course we were a little bit afraid, and so we were pulling a balloon up, but before we could even place the balloon, then the hemorrhage was stopped. So it stopped within a few minutes.
Because I imagine if you saw the catheter beyond the aneurysm boundary, the worst thing to do would be to deploy the web outside. You know, like that's what I think. The difference here is that the coiling, we felt comfortable doing that maneuver, but in your case, I guess the best thing is to cork it and bring a second catheter with a balloon, probably, right?
Yeah, that was what we intended, but it wasn't necessary.
William, thank you. Your presentation, I think, is very, very, very big experience and very, very complicated to treat the patient with a normal doctor. Maybe you are an expert of web. My question is, how many cases you are a failure case? Failure case is impossible to navigate to the web, and your first choice in acute phase is to treat it with the web, but sometimes you are the bigger catheter is not the small is 21, the second is 27, and the third is a catheter to deploy is very, very high, no? To navigate. Sometimes you are very difficult.
Yes.
No, sorry, very difficult. And when you're going to the aneurysm and you navigate with the web inside the microcatheter, you are high force, and it's possible you rupture the end of the fundus of the aneurysm, because the end of the web is, for me, is a dagger. In the control case, in many cases, you are a remnant neck, and this neck, you are the control 1 year follow-up, 2 year follow-up with this remnant neck?
No, we have some MRAs now, and we have not seen changes from the angiograms with the follow-up MRAs, but we have to further look into that. The web technique is surprisingly simple. It is we didn't use the thick catheters, so we almost exclusively use the smaller webs, as I showed you, the 4, 5, 6, 7 that go through a 21 catheter. And the 21 catheter is very stable. It is rather easy to navigate, and the web is going very smoothly through the catheter. And so it is quite simple, the technique. And we had the opportunity lately, just before Christmas, to start with the new Web 17 system, which goes to a 17 microcatheter, and that is even much smoother than through the 21. So we treated now 6 aneurysms with the new 17 system, and so that will come on the market soon, and that is even more simple.
What is the catheter you recommend? Which one?
It is the VIA 21. It is specially designed for the web. Yeah, yeah, and it is a stable catheter. It can be shaped. But
you know the paper of Munaye. I have a study of the Luna. It's the modification of in the control. You have the modification the endosaccular device. You are this experience with the web. It's changed the position after 6 months or after treatment. Sometimes another intrasaccular device is possible to move because the nitinol changed the morphology. I don't know why. You have this.
Yeah. I show you the PCAM aneurysm, which was the web a little bit distorted after 3 months, and the compression of the web does occur, and in many cases, but that's not a problem for the occlusion, because the aneurysms stay completely occluded, even if the web is compressed. So the compression comes from the outside and not from the inside. And so that's not a problem, but there is a change in web configuration at follow-up. Yeah, you were right. In many cases, yeah. No.
I have one question. You showed one case followed by clipping surgery. It is easy after web placement. Is it easy?
Oh, the clipping after the web?
Yeah.
No, it was very difficult.
Oh,
and our neurosurgeon said, well, that was once and never again.
Thank you.
You keep anticoagulation after deploying the web, or not?
Anticoagulation?
After deployment the web, you keep the patient under anticoagulation?
No. Yeah, why should you?
Because the complication was related to embolic complication, most of them.
Well, in the case that I showed you with the wide-necked MCA aneurysm, we should have, and now we do it on indication if we feel that there is a high plane of a big plane of contact between the web and the parent vessel, and if the aneurysm is sealed, then in some cases then we give antiplatelet medication.
You are the contraindication of to use the web? Contraindication, aneurysm. Yes, it's not a good case.
No.
What is you? Or do you think is every aneurysm is possible to treat with web?
Yes, it is just a positive selection. I mean, you can't treat a big aneurysms, or you can't treat the very small aneurysms. You can't treat with a very with the limited height. So flat aneurysms you can't treat with the web. So the web has to fit in, but you know that beforehand, if it fits in, yes or no.
When you are the vessel proximal to the neck, you don't have problem to occlude this vessel. Sometimes you are the branch of the inside the aneurysm is in the sac. Yes. What is the? This is no problem.
They are very difficult to treat. Some aneurysms are very difficult to treat, and a difficult aneurysm remains a difficult aneurysm with whatever technique one is using, and we still send quite a few aneurysms for surgery if we think that it is unsafe to treat it. We're afraid of occlusion of side branches, or then we send it to surgery. But only if we are reasonably sure that we can treat the aneurysm in a safe way with the web, then we proceed. So it's a positive selection, and not all aneurysms we treat with the web. but the majority we do.
Now we have the coffee break.
Thank you.
Podemos hablar, Marco.
Ok.
Sí, estamos tomando un descanso y estoy comunicando con José para experimentar que podemos hacer preguntas. Espera.
Está muy baleado ese.
Oh, ok, ok, ah, sí, qué bueno. ¿Dónde está? ¿José está allá? Hola, ¿puede oírme? No sé si José puede oírme.
Este debería estar.
Sí,
es de grasa.
Es lo siguiente que voy a hacer.
Hola, ¿puede oírme?
No.
Está bien, perfecto.
Ok, entonces tenemos aquí.
Agora não estamos mas podemos esta próxima charla.
Sí. Si quieres, vamos. ¿Cómo te quieres, no?
Sí. Pues debería mostrar.
Deberíamos hablar.
Buenas noches, soy Dr. John Bennett, Alexander de Miami, para el Congreso de NeuroInterventional Radiology de Madrid, sobre la dirección de los tipos de
John Bennett. Es John Bennett. Sí, lo conozco. ¿Eres de acá?
No, porque ya me he conectado de varias veces.
Sí, sí, Marco. Marco.
Sí, doctor.
Sí, tú puedes ver, porque yo quiero practicar con Obama. Es la razón, porque necesito comunicar, probar, para ver si puede ver.
Exacto.
Y no es fácil.
Sí, hay que practicar.
Sí, necesito experimentar.
Yeah.
Conectamos desde otro equipo. Estamos dando invitación.
You are connected and you want to know the situation.
Una sociedad de teléfono de
Sí, hay otro. Hola, hola. Sí, no sé qué puede hacer. Sí, es otra hangout, ¿verdad?
Tiene, lo que creo que pasa es que tiene su audio muy alto, entonces lo que le llega es su propia... ¿Ahora?
Sí, está bien ahora.
Los bucles esos son porque le llega al centro del micro, ¿no?
Sí, puede oírme. No sé.
Solo con este, ¿verdad? Ordenador, yo es que no tengo... Ah, no, 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 ya sé lo que pasa.
Okay. Sí, experimental, estamos probando. Si sirve bien, si no sirve bien. Ok, vamos a experimentar. Oh, mi audio, ok. Oh, mi audio, ok. Yo voy a mutar.
Él se ha muteado, ¿eh?
Sí.
Él se ha muteado para evitarlo. Claro, él está entrando su audio.
Para que él pueda hablar. O sea, ¿cómo hacemos para...? Para. Porque a ver si él tiene que hablar en un momento, ¿no?
Pero él lleva cascos puestos, o sea, él no está recibiendo por casco su propio audio.
Claro.
Entonces no es de él, claro. Lo estoy viendo ahí el casco. Es que cuando aquí llega el sonido, sale por estos y...
Claro, el problema es que se mete, claro.
Se mete en nuestra...
Se mete en el altavoz del micro, ¿no?
Sí.
Sabes que cuando uno hable tiene que... Claro, tiene que cerrar el micro, abrir, cerrar, ¿sabes? Si no... Si lo que se va a meter en un bucle.
Sí, con retardo, claro. Un poco de retardo. Será por eso, ¿no? Pero, ¿has apagado los micros?
Sí.
Intenta que hable ahora, tío. Dile que pruebe a...
No, los micros los he parado por seguir escuchando ese bucle.
¿Sí?
Claro, yo entiendo que si él habla, o sea, él habla, entonces, eso se mete, sale por los altavoces y se mete por los micros. Yo creo que ese es el bucle que se crea.
Se mete por los altavoces, sale por los altavoces y se mete por los micros, sí, pero si con los micros apagados saliera solo en directo por los altavoces, no debería de crear ahí...
Claro, la cuestión es que cómo contestan los ponentes si no a través de un micro.
Hay que
darle...
Hay que activarlo cuando él pare.
Claro.
Un corto cambio casi, tío.
Sí.
Es que si no, a él le va a llegar su propia voz continuamente, ¿sabes?
Claro.
O sea, se va a crear ahí...
Estamos súper lentos.
Estamos fundiendo la red, ¿no? Vamos a hacer una prueba, pero con...
¿Puede oírme, José?
A ver.
¿Puede oírme, José?
Es que no vemos, ¿eh? Espera que voy muteando aquí.
¿Tú puedes oírme?
No vemos nada.
Quizás he bajado yo
¿El sonido de sala?
Sí, tú puedes oírme.
¿Está bien? No, en el ordenador no, tío.
Hola, José.
Aquí llega, ¿eh?
Vale.
Ese es de Salatir. Un segundo, no sé si nos oyes, un segundo. Por favor. Yo no te oigo. José.
Este está muteado, ¿no?
No. ¿El ordenador este?
Sí.
No. Si quieres.
Pero claro, si lo muteamos no va a entrar nada dentro. ¿Qué es lo que entra aquí? Vale. ¿Qué podemos hacerlo, tío? ¿Me puedes decir antes de que suba? A ver si se oye. Vale. Un segundo.
sea, que puede ser lo que manda mi ordenador, pero lo acabamos de mutear, ¿no? José. Lo
No,
acabamos de mutear.
el tuyo no está muteado. Está muteado el mío.
¿Sí?
Ah. La cuestión es...
Sí, está muteado, ¿eh? Lo he muteado yo ahora, tío.
¿Ah, sí?
Mira, ahora está encendido. ¿Habéis probado bajando todos los micros, sí?
Sí.
Okay, mi mute no están.
¿Ahora?
Sí, muteado el mío.
Wow, sí, sí, tú puedes ver mi pantalla en la screen. Entonces,
bien, vale.
tú estás controlando.
Vale,
¿verdad?
de acuerdo.
Vale, guay.
Sí, si yo puedo hacer preguntas de aquí, ¿tú puedes oírme o no?
Sí, sí.
Oh, ok. ¿El auditorio puede oír?
Aquí sí, ¿no? Sí, en esta sí.
Entonces tú necesitas controlar la pantalla. Yo no puedo.
Vale, ok.
Sí, yo creo que tú necesitas cambiar pantallas. No puedo. Si yo estoy cambiando ahora, pero no sirve. Tú necesitas cambiar. Por ejemplo, una persona como yo que tiene una pregunta, tú necesitas hacer que ha hecho. Poniéndome allá y puedo hacer pregunta. Oh, buenos días, Madrid. Bienvenidos a Miami. Soy John Bennett, tratando de arreglar, haciendo preguntas de afuera a Madrid. Y sí, esto sirve. Para mí, no sé. Ok, puede cambiar pantallas. Marco, puede hacer pregunta para. No bien. Ok, Marco, ¿puede hacer una pregunta, por favor? Marco. Marco. No puedo, ok. Tú puedes oírme, ¿verdad?
Sí.
Ok, tú puedes oírme, Marco. Marco, ¿tú puedes oírme?
Sí, claro que sí.
Ok. Puede oírme en auto. Ok, Marco, ok. Sí, tú controlas la pantalla. Tú estás poniendo Marco.
Sí, está bien.
Marco, diga hola, Madrid.
Buenos días, Madrid. Les hablo desde Cochabamba, Bolivia.
¿Tú puedes oír, Carlos? ¿Tú puedes oír, Carlos? ¿O José? Oh, sí, puedo oír. Ok. Entonces, si hacemos cambiar pantallas a mí.
José,
Ok. Entonces, tú necesitas controlar la pantalla. Sí, eso es. Entonces, José y Carlos y Antonio, tú necesitas controlar la pantalla. Una persona como yo puede hacer pregunta. Madrid, ¿verdad? Sí, excelente, excelente. Podemos hacer preguntas de Miami o Cucabamba o cualquier parte. Entonces, tú necesitas controlar cuando tenemos preguntas, necesitas comunicar. Dicen, ok, José, hay un huésped que quiere hacer pregunta, como, por ejemplo, tenemos un huésped de Bolivia, Marco. Marco, tiene pregunta. Y necesita cambiar la pantalla. Marco, hace pregunta.
Marco se desconecta o que se pierde esa conexión, tío.
Marco, hace pregunta. Espera, sí, ella está tratando de poner en la pantalla.
Pues somos nosotros.
Está bien, no sé si pasa con... Marco, ¿tiene buena conexión o no?
Marco se pierde la señal.
Marco, ¿puede hacer pregunta?
Él está desconectado.
Doctor. Sí, no tengo ninguna pregunta por el momento.
Oh, ok.
Después.
Ok. Well, yo creo que ellos entienden. Oh, Marco, no mute, ok, habla. ¿Puede hablar, Marco? Hacen pregunta, por favor.
Ese micro está... Ese micro lo tengo yo.
Marco, ¿puede hacer pregunta, por favor?
Hola. Sí, en este momento no tengo ninguna pregunta, doctor. Sí, en la siguiente presentación vamos a...
Claro, cuando yo, claro, lo que yo te decía. Sí, que el audio...
Ok, no sé.
Sí, cuando tú activas el audio.
Ok, bien. Ok, José. Ok, está bien. Podemos... ¿Quiere hacer o quiere esperar? Ok.
Dile a Antonio que quite las...
Cerramos directamente la conexión. ¿Cómo? Sí, la ha quitado, ya la ha quitado.
Ok. No necesito usar ahora, José. Yo quiero experimentar para probar. Tal vez más tarde. ¿Entiende, José?
Hello, everyone. We're going to continue with the meeting. Professor Jacques Moret could not come today because personal problems. We apologize for that. We're going to continue with Professor Dimitrios Lopez from Chicago, who will talk about endothelialization process of stent with or without surface modification.
So thank you so much for this invitation. I think that this is going to be, first of all, I think two goals we'd like to have with this presentation. First one is to introduce to you maybe a new way to evaluate devices, and hopefully this is something that you will agree with me. It's a very challenging concept when you have the development of a new technology, how to assess the biological response of this technology. So I'll share with you the experience we have had with using optical coherence tomography for that, or intravascular imaging using the OCT technology. And the other concept is the introduction or the new frontiers in flow diversion, which is something we talked a little bit about earlier today, which is what is the impact of surface modification on the need of antiplatelet therapy. So the important thing about this concept is to see, of course, the evolution. And today we had the opportunity to see a discussion on the preference of using steel coils, and something that we've been very familiar since 1990. But over the years, for one reason or another, there has been a need to develop new devices because there's such a wide variety of pathology that we treat. And the use of flow diversion became available as a concept, I have to say, much earlier than 2011. But it took a significant amount of testing. And I have to say to you that compared to many devices we have, I think that the amount of in vitro and understanding of how the performance, mechanical performance of this device was done prior to approval, and also the approval process, the types of trials that were done to get this device approval is it's very unique on the aneurysm area. You know, in the aneurysm area, a lot of things have grandfather. And you talk about clips or coils. There are no studies showing that this was actually the best therapy. It's all we had for the treatment kind of thing. But flow diverters had to prove themselves compared to the older therapies, and not necessarily something we see often. The only thing is being the biological response and how the coagulation control is done, and that's something that's been a challenge. But as you remember, we have used the concept of flow diversion is something that I would like to challenge you. If you today could tell me what it means to have flow diversion, is that when you make multiple stents of low coverage together, you have an impact of altering flow from an aneurysm. Maybe you can do one device only, but flow diversion can happen in many different ways. And the modern era flow diversion, it tends to be about 30% metal to artery ratio. But this is something that I will be glad to discuss and hear your opinions on what means to have flow diversion. I think that there's no question that over the years we have worked tremendously on the concept of going from coronary stents to self-expanding stents, and now flow diverters that are self-expanding platform. But this is an evolution only on design. And we have not, we basically have not seen what is the potential, what's the next frontier after development so much these devices, what else can we do? And it's true that the amount of trials that you have here also allowed us to understand quite a bit what the current devices do. And Premier, I don't know if you're familiar with this, but this trial we just finished in the United States is to increase the indication from large and giant aneurysms to small aneurysms now. So flow diverters are going to be used in a very wide spectrum of indications nowadays. But then comes Shield, and Shield is basically starting with first in the pipeline platform, but likely will move on into different platforms. Is basically the concept of surface modification. Now, why this is so important is because if you look at the use of a flow diverter, the way we know today, 30% coverage, it has shown to us a tremendous improvement compared to the stent and coil information that we had from before. There's not a head-to-head comparison, but if you're able to look at this table and you compare the trials that used the flow diverters, the main flaw of the concept of flow diversion perhaps is we can do better on the complication rate, the morbidity and mortality, specifically thromboembolic events. So we saw earlier today, Dr. Henk is presenting a very complex, very large series of flow diverters. And again, thromboembolic complications, even though it's an acceptable complication rate, we can still do better in there perhaps. So we have worked on design, but now how can we do better in terms of protecting our complication rates? The main thing between stent and coil or coiling alone is the issue of durability at a complication rate is acceptable. So this is the biggest advantage of flow diversion over any other treatment that we have today for wide neck aneurysms, is the occlusion rate and sustainable occlusion rate being much better. This is a very interesting data from a study that pulled the data from all the flow diverter trials using pipeline. It's about over 1,000 patients, but multiple centers. And this is basically showing to you pretty consistently across different studies that over the years, there is a progressive occlusion of the aneurysms, and they tend to be durable. And the retreatment rate being pretty low, and major morbidity and mortality for a large and giant population aneurysm around 7% on this pooled data. Now, So what is the biggest issue then? I mentioned to you many types of complications you've seen earlier today, many types of complications, but thromboembolic events, it's really the Achilles heel of flow diversion. So this is actually in a FDA database. You can see the biggest complaint about stents is instant thrombosis or thromboembolic events. So this is a big deal. The problem with this condition is that there's no one solution to it. And we will see later on today a talk on anticoagulation, is that this is not about only the device. It has to do with the procedure, has to be with the patient. There are many conditions that affect the thrombotic state of a patient. So we have to look at, if you look at these different circles here, the strategies that we have to minimize thromboembolic events has to come as a multifactorial type of situation. Now, I have to pose to you that in flow diversion, the next generation of improvement probably will come from surface modification. And I would like to pose to you that intravascular imaging will help us also on this multifactorial approach to decrease the number of complications we have with flow diversion. Okay, so why I think this is important is that if you look at the surface modification issue, it is something we can do. The technology exists for that. We have in the coronary arteries already some proof of concept of surface modification. So you're not coating the device, you're actually modifying how the device is made to decrease its affinity to form clots, I guess, and look more like a red blood cell. That's the initial concept we have. So this is what this shield technology, by adding this PC polymer of the device, so you're not coating the device is not changing in size. So this is a very important concept, that you're not making the device harder to use. The device actually should perform the same way as the original device. You're just making the device in its constitution add this PC polymer to it. And that seems to have an impact on decreasing thromboembolic events, or the affinity of the blood coagulation cascade to be to the device that is implanted. So the stent or the flow diverter look like the outer membrane of a red blood cell. This is how this looks like. It basically it incorporates into the braid of the stent this PC, and this PC polymer will be basically affecting that thrombogenicity. Some of the studies in vitro, and this is one that's very, I suggest you to take a look. The General Neurointerventional Surgery showed this in vitro study comparing the different flow diverters, one with multi-layers, one with single layer, one in using also dual antiplatelets and without dual antiplatelets to see the impact. And you can see here that if you use, these are the different curves, and you look at comparison, the triangular one is Fred. If you can have the normal pipeline in the square, and the circle is a shield technology, the pipeline with the surface modification. And if you use no antiplatelets, you tend to have a separation between them. As you can see that the multi-layer tend to have a little bit more thromboembolic formation, and the shield technologies, it did better in vitro compared to the regular pipeline. But if you have one antiplatelet, you can also have that separation. But if you use dual antiplatelets, that separation, it doesn't have so much of an impact anymore. So it's showing that there was a question earlier today, can you use a single antiplatelet in a hemorrhagic case and place a flow diverter like shield? There may be an advantage to that based on in vitro studies compared to the need to use dual antiplatelet. Now, this is, I think, is very telling what is happening in vitro. But if you want to see the picture of this, this is now fibrin deposition, and you can see the difference between different devices. And clearly, there seemed to be even within pipeline, shield versus regular pipeline, also less fibrin deposition on the device. Okay, So now we have the technology for surface modification. We have some in vitro studies. Let's move into the other area, which is the intravascular imaging, and where we are with that today. I think the most exciting thing is that this is what I'm going to show you today is using a relatively large catheter. It's a St. Jude product, but we have a wire, a 14 wire, that will provide us the same type of imaging, perhaps even better. And this is at the neuro level. So a 14 wire malleable that can go intracranially. It allows us to obtain this type of information. So imagine if when you did your flow diverter placement, you could see the strut apposition like this. You could say, do you need to angioplasty or not? But this is nothing. I'll show you even more further analysis on this. You can also, not only in the acute phase, when you deploy the device, analyze if it's a good deployment. You can on follow-up see how much the struts are being covered by endothelium. There's a difference between IVAS and OCT, and I think this is kind of just shows you the spectrum where OCT is in terms of the type of imaging acquisition is a light-based acquisition, so you need to remove the blood at the time you obtain the image. So for you to do that, we have special techniques, but the faster the scan is done, allows us to minimize the time that you need to remove the blood from the circulation. So an injection of contrast allows us to obtain an image during that time. Now, one of the challenges has been the Circle Willis, because you can have blood coming from different directions. So we are learning more and more how to improve our imaging. In our studies, this is the equipment we have used, but as I mentioned to you, I would not sure if I would start with this. I would wait until this new technology becomes available and you're able to use a much smaller catheter than you see here. This is a relatively large system, but the way this works is basically you place across the lesion, and then the inside of the wire or the catheter, a light source will go up and down. This is in a cadaver. You can see the basilar artery in a cadaver, and then you can see the light moving down the vessel. So this is how the beam or artery scan, the light goes up and down the wire or the catheter, and the image is obtained at the section where the light is as it goes up. But as you do this, you have to clean and with contrast or saline so that the image is clean. Sorry. So this is a little bit of a comparison between the intravascular ultrasound and OCT. OCT is at the level of histological information. So as you do an OCT imaging, you're looking at the vessel as intima media. It's a different level of imaging. That's why I think that is the next level for us to decrease our complications. We're going to see more. You can see the perforators. You can see, but the problem here is penetration. We cannot go too deep. So you have about a 6 to 7 millimeter scan. So if the vessel is too big or there's an aneurysm attached to it, you may not be able to go deep enough into the aneurysm. In that sense, the IVAS does have a better technology in terms of how deep you can image the vessel. But the precise vessel measurement, it's something that you'll be pretty amazed how our conventional techniques are not giving us necessarily the best sizing. And we all know that sizing for flow diverters does have an impact. The other thing is this amazing image of the origin of perforators. And the interesting findings, I never knew that a perforator the ostium, internal ostium and the external ostium were not exactly the same plane. They actually, the artery travels within the vessel wall and comes out in a different angle. So the internal ostium and the outside ostium of a perforator. So Naji showed us beautiful pictures of mini aneurysms on perforators beyond the vessel, but we cannot see in the vessel the perforator. And this is what we're seeing here. This picture is actually in the vessel wall. You're observing the trajectory of a perforator. But this allows us to also see the relationship between the branches and the devices that we place. If we can actually choose, we also saw today top of the basilar flow diverters. Maybe the nice thing would be to map that area and see the amount of perforators you have and decide what kind of coverage you can use. And if you talk about covered stents, even better, you can then choose which territories you can place the device based on a true imaging, allowing you to see what the vessel looks like. You can make diagnosis of injury like intimal tear as well as plaques and if you're in a true lumen or not. Now, this is the look of a basilar artery with a pipeline, and you can see the relationship of the little tiny struts. So now you can design devices that will have the best shape into the vessel. We cannot see this type of picture very easily unless you do histology. But imagine this type of picture now in a very dynamic world that you can actually follow over time in the same individual, on the same animal in the case of our study. So this is a comparison between an enterprise and a pipeline, how the difference between a low coverage, maybe a 6% metal to artery, to a high coverage, 30% metal to artery, the density of the struts is very different. And this is actually a case that we're able to get an IRB approval to do, was a multiple stents with coil in a human, a live case, that we had to stop the aspirin Plavix. So we wanted to make sure that the endothelium had completely covered the construct. This was relatively early. It was maybe about 3 months from the intervention. And you can see that the neointima had formed completely throughout the stent. We can actually measure at the length of the device that it has been completely healed and potentially be very safe to stop aspirin Plavix. Now, this is, of course, opens up to, if you go to bioabsorbable stents and different technologies, that you can now follow up how the absorbing factor is taking place in the healing of the device. So imagine how much more we can do if we can actually see this. Now, I would like to start focusing a little bit more on what we did, which is endothelization is very appealing to me. And this is an example comparing different devices, and you can, this is the stent you can see here, but you can see that this is the number of frames. So each study may have over 280 or 300 pictures of a millimeter difference of where a histological section. It's actually very difficult for you to do a histological comparison because the macrotome cannot cut the device as close as the OCT can do. So you get much more views of the device. Now, this is the example that we found out to be extremely relevant for the evaluation of new devices, is if you have on day 0 and day 21, and you bring this animal for studies in different time points, in this case was every week we're doing that, you can actually see in the same animal the growth of the tissue over the device over time. And this is what this is showing to you, is basically going from no coverage to complete coverage of the device. And you also can see where the neointima starts in the healing. And this is now, we're moving to a better visualization of this with this type of reconstructions here. So this is a 3-dimensional OCT. So you can see the lumen of the artery, and then you can see the neointima starting to cover the device until complete coverage. And that type of reconstruction is something that allows us to think about other things. You can now do potentially a flow dynamics study knowing exactly where the device is in place. So by knowing the strut position after deployment, you can use that for CFD calculations in a way that we couldn't do before. Most of this is done as a virtual modeling. And when you place the device, you place a fake device or a virtual device inside of the blood vessel. But having the true detachment of the device measured like this allows us to give to the computational calculation a much better idea of how to simulate that. And this is the type of views you start seeing. Now, there's something very interesting about this, which is, let me show you this picture here, which is a reconstruction of the device with the ostium of all the vessels that are in relation to the device. But the most exciting thing, and I think you really should pay attention to this. Look at this. This is the vessel. And right here you have in microns, the distance between the vessel apposition in microns in the different parts of the stent. So if it's white, it's well opposed, so you don't need to angioplasty. But if it's yellow or red, so you see the red area here, that means that it's more than 300 microns away from the wall of the artery. So if you have more than 300 microns, in cardiology today, this is a indication for angioplasty. So you can actually get a quick view of the whole vessel with the stent deployed, with color coding in the areas that is separated from the blood vessel wall. And that will give you an incredible map of where it's relevant to angioplasty, not just angioplasty everything like we do today. So this is how it looks like. The white is well opposed, yellow is a little bit less, is about 200 microns, and red is 300 microns away from the vessel wall. This is how it looks. So 200 microns well opposed and 300 microns away. Now, this is another great view. This is with a Fred device across the anostium of a perforator. Look at how many little struts, because it's a braided device. So it has two, I'm sorry, it's a multi-layer device. You can see the difference in the strut size across the ostium of the perforator. And this is really interesting. You can measure, you can work on understanding the relationship of this device to the ostium. This is a branch, not a perforator, but you can see the jailing of that branch and how little you cover the ostium of that. You can actually calculate the area that you've been covering your perforators and branches. Okay, now this is gonna go quick, but I wanted, this is really exciting though. We had an opportunity to study shield versus pipeline versus solitaire. And we decided in an animal model, you use a pig for that. And the pigs were, we chose basically two groups, one with dual antiplatelets and the other one with single antiplatelets. And so this is the protocol. They all receive, I don't know if you know how you give aspirin Plavix to a pig, but we use donuts. So you put inside the donut and they eat the donut and the aspirin Plavix. So it's kind of interesting. They have preference what kind of donuts they like, so it's very picky. But this is how they look like. So this is in the lab. We do general anesthesia for the angiogram. This is our procedure. You just get them prepped up there. This is the procedure, the endovascular part of it. This is, we use Navian, Marksman, and the OCT catheters from the Dragonfly Optis from St. Jude. And we randomized, so we didn't know, we placed in the carotid arteries if it was flex, shield, and solitaire. We're blinded to the shield and flex combination. So this is the system we use, over 14 guide wires, a 2.7 French catheter. So the main issue about this, I won't discuss too much the OCT process, but the femoral artery access is a bit of a challenge sometimes. We would go ahead, do an early OCT post-deployment, and then we'll bring the animal in different time points up to 21 days. 20 days, every one of them was completely healed. For the femoral artery, we usually tried, the cut down seems to be the best method to do. This is a little bit of the anatomy. We can go over that if you'd like to do it. But the main thing here is that, yes, the carotid artery is a very straight shot to get there. And each animal got 4 devices, 2 in each side. And this is how they look like post-deployment, the distal and the proximal one. And this is now us doing the OCT during the this procedure. This is very important, which is the flow rate, the injection of contrast to clear the blood. It has to be, there is a science to that, how much volume and what is the rate to use for that to happen. And this allows us to get this kind of pictures. You have the flex, the shield, and the solitaire. And this is in the different regions. This is the one that we're looking at, 100 frames. The 100th cut within the device. This is what these 3 devices look like in the day 7 post placement. And this is now at day 21, showed complete coverage of the device and well healed. how this looks like in how you compare and how beautiful. I mean, these images are very clear. As you can see, we're able to remove the blood very well there. And this is now the beginning of neointima growth at 7 days. You can see a little bit of neointima over there. You see that? It's strut. It has a little bit of coverage, and it's very symmetrical on the shield. And I'll go over this with you. And this is at day 14, a little bit more. And now at day 21, and you can see the angiogram and the DSA as well as the reconstruction matching very evenly how that growth of neointima was happening. And then we did a histology, and even in the cases that there was thrombus, it correlated very well with the histology and the OCT. So I think this is a very good, but of course, this is the limitation of histology, is only one time point. We are able to now obtain data from the acute stage all the way to the histology time using OCT. This is an incredible finding, which is the growth of neointima on top of the blood clots. And this is what I think Dr. Henkes was alluding. Sometimes you'd see a stenosis that goes away. Maybe it was just clot on the wall of the stent. And we definitely saw that happening here. Let me describe to you what we measure, and this will show you the comparison. So we measure the lumen area, which is the green line. The white line is the stent area, and then where we have this black arrow here is called the maximum thickness. And then in this area here, the red one is the minimum thickness. Now, this is the definition from cardiology of what is a coverage. And then the coverage struts are this type 3 and 4. So you have different ways this has been well established. So we follow that cardiology convention. And we measure this type of, this is the data that I'm challenging you to say maybe new devices should be evaluated like this, is the neointimal ratio, which is the lumen minus the stent area divided by the stent area. The endothelization ratio is the type 3 and 4 that I showed you. And this is the important, how fast that happens. And the thickness ratio is, for an aneurysm, imagine it's how much you separate the lumen of the vessel to the aneurysm. And that is the minimum over the maximum thickness. Now, just to show you the OCT data on the patients with the animals with single antiplatelet use. And this is the information we got. I will not, I will kind of summarize this for you, but I'll be glad to discuss this in more details if you have interest. But the interesting things about this were that the neointimal formation over time, it was clear that at day 21, everyone had neointima, but from the beginning, which is very surprising to us, the surface modified device had the fastest growth of neointima. And this is something that was against what I expected. I thought that the surface modification would delay the endothelization. This for an aneurysm perhaps would not be a good idea. But in this case, it seemed that we saw consistently faster endothelization on the shield device. But over time, it catches up and the other ones will heal. Now, there are many theories why this happens. It may be because the steps of healing are bypassed when you do a surface modification. The device is already pre-ready and can start endothelization at a faster pace than the ones that need to be first go from a more premature state of healing, perhaps. By the surface modification may change that. Now, the neointimal formation percentage on each position over time. So we checked distal, middle, and proximal portion of the stent and compare if there was any healing happening in different locations. And that proved to be very random. So if you ask today where the endothelization starts in a device, you cannot say that starts from the edges. People say, oh, everybody says, oh, it starts from proximal and distal. It's a random process. You cannot prove that consistently starts from each end. It randomly starts, and this suggests that this is something from the blood that implants on the device and then develops the endothelization, not that the endothelization starts from each intima on each side of the device, which is an interesting finding for us too. The other thing is this is just going on the same type of information I just shared with you. It's very random how that happens. For each device, Solitaire, Flex, and Shield, we saw the same random pattern of growth of neo-intima. Now, the neo-intima thickness ratio, it was very important to say that the Shield had the most significant thickness of neo-intima on day 21. And when you combine the single and dual antiplatelet, and now here you can look at the differences of thrombosis. Maybe this lower part is the most interesting, and I'll summarize this for you as we move forward here. The view, if you have single antiplatelet versus dual antiplatelets, the difference on the neo-intima ratio, you can definitely see that there may be a difference by using single antiplatelets on how the neo-intima heals over time. This is the graph showing that there is an earlier initiation of endothelialization on a Shield device, and this was shown when you combine the groups also. Now, thrombus formation, that's the biggest question, I guess, is clear. Like when we use single antiplatelets, the black one, the Flex had 100% of thrombus on the stent struts. But in the Shield had with a single antiplatelet, much less, a significant less thrombosis. And if you use dual antiplatelets, then it becomes all equal. So it's hard to see the difference in surface modification when you're using dual antiplatelets. But if you use single antiplatelets, you see a difference between them. Now, to conclude, is basically, I'd like to challenge you if you think that optical coherence tomography could be a new way to assess the new devices, especially in the parent vessel. I think when it comes down to the Shield endothelialization, we show that there is a tendency for earlier neo-intima formation. We also showed that the volume of neo-intima formation over the Shield in day 21 was not significant compared to Flex. So over time, they become similar, but it starts sooner with the Shield. We also noted that there's a more concentric, a more symmetric healing of the neo-intima in the Shield device compared to the other ones. And the pattern of neo-intima formation is random. This is a very interesting finding. We also noted in the acute phase, there was 100% thrombosis in the Flex device, and there's 2 out of 6 on the Shield device, and that was also an important finding. We changed the protocol because we saw in the acute phase thrombosis, so then we started giving dual antiplatelets, even though we had originally started single antiplatelets, because we had proved the point that there was a difference between them. So after we started doing dual antiplatelets, then the Flex and Pipeline Shield behaved the same way. So there's no more thrombosis after dual antiplatelets were used. Thank you so much. I invite you to come to WNC in Los Angeles in May 15 to 17. We're looking forward to a very lively discussion of cases. And I have to put a plug to Neurovascular Exchange, which is really an educational platform. It's a free online registration. I encourage you to check this out. And this meeting is actually being broadcast live as we speak to this site now. Thank you so much.
Thank you, Demetrius, for this amazing presentation. Have any question in the audience?
Well, first of all, congratulations for this great talk and this new technique. I was wondering, I have a couple of questions. The first one is, do you think this technique, the OCT, it's useful for make the diagnosis of blister aneurysms? Because a lot of times when we perform the angiography, we see those irregularities that we are not sure if it's a blister or not. What is your experience with this technique? Thank you.
Yeah, I don't have experience with blisters, but I think that if we increase the safety, unfortunately, it's an invasive method to prove that. Maybe you can argue that having to do an angiogram. So the fight here, or the debate, is between MRI wall imaging versus intravascular imaging. So if the non-invasive technology gets to a level that you can do imaging of the vessel wall with MRI, which we're seeing more and more of that, perhaps that would be the preferred method for that in an acute case. But no doubt, you have a histological information. You could argue even to do screening of vessels to see where there is 2 layers versus 3 layers, for example. So predisposed, if you have familial aneurysms, you know, and you can actually make an argument for that perhaps. This is far from where we are now. I think that the initial application of this will be mainly on treated cases to follow endothelialization and so forth. But I think that the images are incredible, but it's an invasive method to do so. So you have to balance that.
Thank you, Demetrius. Why you are the different thickness of endothelialization? Do you think it's to the flow component, change of the flow, or why? Why is different? I see in the image you are more endothelialization, no in the neck, in another side. Why? What do you?
Well, I think that the response we're learning from this, but what's interesting for me is that I don't know if there was more opposition against the wall causing more response. So if we see this in carotids, if you place a carotid stent, many times looks on follow-up that the stent is outside of the vessel and the contrast column is in the middle, but there is a thickness of neointima that grew. There's a tendency for the blood vessel to reconstruct the neointima to the original size of the vessel. So if you have oversized stent, it will narrow enough. It's called late loss, which is the growth of neointima inside of the device to compensate for whatever radial force that you apply against, or angioplasty or stent force. So it may be a component of that. We noticed that not only there was a difference in growth in neointima, but also the symmetry of the 360. Sometimes there is thicker in one side and thinner on the other side on the same cut. And we don't understand that very well. It could be that there is clot in the stent, and that made the neointima grow over that. It became more. So we saw in some cases that as an explanation. There was a coverage of neointima over clot. And the other reason may be related to the strength of the apposition or how the device is deployed, technical issue, maybe.
Okay. The second question is, when I stop the endothelialization, how many days, how many?
So
you are study this?
Yeah, so in the animal model, it's 21 days. But
1 day to start and stop?
Then we stopped, yeah. But once you finish complete coverage of the device, we didn't see any, we didn't follow long enough to see if there was overgrowth of neointima. Perhaps you could argue that you could look longer for stenosis then. So this study didn't mean to look into that, but I think that it's an interesting question. If we had a device that caused a lot of long-term stenosis, we could try to study when that happens, and I think that's a possibility.
Finally, I suggest you it's possible to put the endovascular device to see the ultrasound, to see the endothelialization. It's possible to put this material and no remove. You wait 1 week and you learn you need weight growth. It's possible this?
I think it would be not advisable because of the vascular access. You'd have to be still, right now it's not a wireless situation, so you would have to be coming outside of the body. So the patient would be very limited in what they can do. In an animal study, it's hard to justify that type of, even the multiple angiograms. So if you ask me, what was the biggest barrier we had? Well, number one was to get all the devices and the cost of this, but the other one was the issue of to convince the IRB of a project that you have to do multiple interventions. It's a bit of a challenge sometimes. And but I think that if we show the reason why we're doing this is incredible information. We never knew before where the endothelium starts to grow. You know, this is new information. We also don't know the impact of a new device with a surface modification. So I think that if we have a relevant question like that, it's justified to do multiple studies. I don't think that leaving the wire in place will allow the mobility between the time points. You can extrapolate if it's something that heals very fast, like your stem cells or something, maybe you can argue that I want to monitor in an hourly basis, and then you can justify a design that you could do this. The issues would be the anticoagulation that you have to have, and the mobility and the anesthesia time. You know, a pig, you know, once you wake them up, they're not going to hold, they're going to be all over the place, you know, and I think that's the limitation of that. Thank you.
Thank you, Demetrius. We're going to continue. Professor Mitchell, Professor Waha. Stacy.
I will talk on both, but I will start with the MCA because this one is kind of a transition to this one, so that we will not jump from one subject to another. Just keep that just in case.
Professor Stacy will talk about flow diverter for treatment of complex MCA bifurcation aneurysm.
The first? Not the first one. Okay. This is the first one. I don't know what happened. Okay, let me see. What happened to the? Sorry, just a second. Okay. Okay. Oops. No. Okay.
We have a problem with the screen.
It doesn't show up on this side. It doesn't show up on this.
Sorry, wait a moment. Oh, it's very difficult for me. The Turkish.
You have to improve your Turkish.
This is.
Yeah.
I have a problem because I don't see all the screen. You can save in your pen drive.
Just a second.
You need to finish the presentation.
Yep. Okay. So.
Noted.
Noted.
No.
Yeah. And first, the first one. Yeah. Okay. Well. Okay. Well, good morning. I first want to thank Luis for his very kind invitation. I always enjoy being here. And thank you for your hospitality. Today I will talk on two subjects. The first one would be the MCA bifurcation aneurysms, the flow diverter treatment in complex MCA bifurcation aneurysms. And then I will talk on the giant aneurysms. I switched the place in the program, so because it's kind of a transition between the giant aneurysm to posterior circulation, so that there will not be a jump from one subject to another. So I'll start with my first talk, flow diverter treatment in complex MCA bifurcation aneurysm, because in the recent years there's a controversy in regard to this subject. So I would like to present our view and our way of understanding with our experience. One of the most important parts of the revolutionary changes in aneurysm treatment created by flow diverters has been making the treatment possible for aneurysms at the bifurcations, with an important vessel coming off off the sac. This used to be a major limitation for the endovascular treatment. And we described a new aneurysm occlusion process called flow remodeling that I will show many examples in regard to that. In such bifurcation aneurysms, flow diverters not only occlude the aneurysm, but remodel the flow. For example, in this particular example of distal anterior cerebral aneurysm, at the bifurcation, the pericallosal artery got smaller by time while the aneurysm is getting occluded. So flow remodeled the anatomy. If the flow demand of the particular vessel is not needed, is not strong, then that branch may get occluded, and it will simplify the bifurcation, as in this terminal ICA aneurysm. So that because the flow demand is through the contralateral side, we don't need the flow through A1, ipsilateral A1, and by time the aneurysm got occluded and the branch is not filling anymore. Another example, distal bifurcation, this time a FRET device, and it is put through the pericallosal artery that the callosomarginal artery kept same, patent, while the aneurysm got occluded. There is a flow demand through that vessel so that it keeps the vessel open. Actually, we know this mechanism from our side wall aneurysms treated by flow diverters, as in this anterior choroidal artery aneurysm. Even though the anterior choroidal artery is coming off from the sac, despite that the aneurysm got occluded 100%, the anterior choroidal artery remained same and patent. We are all aware of this. We all experience this. But not all the time the flow remodeling is 100% effective on the aneurysm. It takes time, as in this PCOM aneurysm where this patient does not have P1. So it takes time for this large aneurysm to be remodeled. And this was the stable result at 3 years, that the aneurysm got small, got shrunken, and is continuous with the artery. So there is no more aneurysm filling. So it is for us an inspiring case, actually. This is why we show each time we talk on this issue. And if we look at this MCA aneurysm, bifurcation aneurysm, from another perspective, then why not putting a flow diverter, accepting it as a sidewall aneurysm? Before going further, I would like to note that we are very strong believers of stent-assisted coiling at MCA bifurcation when needed. MCA aneurysms for us are not so-called surgical aneurysms. We reconstruct MCA aneurysms as much as possible. In many of the cases necessitating double stent placement. Despite, for example, we can even reconstruct such an MCA aneurysm where both branches are incorporated in the sac with dual stents. And with the, we already published the results with the big stents like Enterprise and Solitaire with acceptable results. And then came up the smaller profile stents. It made the procedures even much easier and much safer. And it became possible to reconstruct such ugly looking complex MCA aneurysms using double stents. And we have acceptable results with those mini stents as well. Our experience basically with Alves Jr. and Aquino as mini stents, but I know people are happy with Baby Leo and Atlas as well. So shall we use flow diverters in complex aneurysms that can be treated with conventional double balloon remodeling or dual stent-assisted treatment? Is just placing a flow diverter in the easier trunk can be a treatment option? For example, in such a case, instead of dealing with dual stents, can we just put a single flow diverter with an effective result? In the other cases that I showed in the previous slide, dual stenting was, or dual balloon remodeling was possible. But how about those? These are even more challenging for stent reconstructed techniques. Wouldn't flow diverter treatment and flow remodeling be a good treatment alternative for such challenging aneurysms? I would like to go over how the flow diverter behaves at MCA bifurcation. All bifurcation vessels may remain patent while the aneurysm is getting occluded. As in this particular patient, the branch is open and the aneurysm completely occluded. Very stable result in the long run. We call it class 1A. I would explain what this 1A means afterwards. All bifurcation vessels may remain patent even while the aneurysm gets occluded, even such a big aneurysm, but it may sometimes take longer when the aneurysm is much bigger. But in this particular case, even at 6 months, it showed a great result, keeping the vessels open while the aneurysm get occluded. Can you imagine how it could be with the dual stent-assisted technique, for example? It can be easy, but it can be challenging as well. Or this one with the nipples all around. So it would definitely be difficult to put a wire inside this branch incorporated in that nippled aneurysm. And however, putting a flow diverter is very easy procedure and very effective. Since the flow demand is not too high, the branch got smaller. However, the aneurysm got completely occluded, a very effective result. Another example, this branch get smaller in the control period in the long run, and the aneurysm got occluded. Another one. So it is not just a coincidence or for one case only, but it is how it behaves. It behaves according to the hemodynamics, but one should play according to the rules that I will mention later. See the branch, the superior trunk got a bit smaller. However, it is still patent and the patient is totally asymptomatic. If there is no flow demand, the branch incorporated in the sac may get occluded. So you may find out that the branch is completely occluded in your control angio, as in this particular case. This branch is coming in a retrograde fashion from the collaterals, but totally asymptomatic. Another example. If there is no flow demand, that jailed branch may get occluded. There is another concept, flow remodeling, as I mentioned in the first slide. If there is a need for the flow, then the bifurcation may remodel according to the flow demand. And this was a recanalized aneurysm that we put a flow diverter here, and in the follow-up, you see the healing reaction at the neck of the aneurysm, and the bifurcation is remodeled. The branches are open, but you cannot see the aneurysm filling anymore. Secondary to flow remodeling effect of these treatments, we have been observing follow-up findings different from those we were used to. So this brought not only difficulties to express the follow-up results, but also caused communication problems among ourselves. So we ended up proposing a new classification for post-treatment results of endovascular treatment, modified from the good old Roy-Raymond classification, which is complete occlusion, neck remnant, and aneurysm remnant as class 1, 2, and 3. And then a class 4, because for the flow modifier systems, we do not see the result immediately in many of the cases, most frequently, including the intrasaccular device treatments. So there's a class 4 for the aneurysm filling. And class 5, this is to describe what we say remodeling, stable remodeling. Class 1, we put subtypes so that we will describe if the jailed branch is patent, reduced in size, or occluded. So this is the schematic explanation of what we are describing. Class 5 is important. It is reserved for the patients who has at least 2 follow-ups spanning for a period of 1 year at least, which shows a stable filling of the neck at the bifurcation, which does not show any change. The only exception is if there's a new vessel path, a tortuous appearance through the neck and through the sac of the aneurysm without filling the sac, remaining sac, then we may call this without waiting for the second angio as a remodeling, as in this particular patient that you will see later. So For example, let's look at this example. We put a flow diverter here, and this is the 15-month control. So are we going to call this little thing here an neck remnant or aneurysm remnant? No, because the flow is continuing through that, and it is the new path of the vessel. So it's a remodeling process. So we cannot claim the presence of aneurysm anymore in this particular patient. So remodeling is basically another form of complete occlusion of the aneurysm. Another example, this is more challenging. This MCA bifurcation aneurysm, a stent was, a flow diverter was placed, and this is the 1-year control. A stable appearance. You see the healing reaction at the neck. Yes, there is a enlargement of the origin of the vessel, but it is necessary to keep the flow into that vessel. If it stays stable, we cannot admit that there's aneurysm remnant, but it is a remodeled aneurysm, remodeled bifurcation. So it is class 5 for occlusion, stable remodeling. Another example, a large aneurysm, flow diverter. This is the 6 months control. At this point, this is a aneurysm remnant or neck remnant, whichever. However, if it stays stable like this, since that branch is continuing through that neck, as you see here, then we may call this stable remodeling. Another example, you see the aneurysm. This is even more controversial, and this is the control. So at the first control, you may say that this is the aneurysm remnant. However, if it stays stable, you see the healing reaction. The vessel is continuing from that enlarged bifurcation. So this is a remodeling due to flow. This is before treatment. A complex shaped MC aneurysm. This is after 6 months, so it does not have the nipples and lobules anymore, but there is enlargement. So this may be a remnant. You call it class 2 or 3, depending on how much is filling. So it's a class 2 occlusion. And in the follow-up, it stays stable. It doesn't show any enlargement. It may get smaller, but does not expand, does not get larger. So it is flow remodeling because the vessel is continuing from that bifurcation. But we need to remember that if we are going to treat the MC aneurysm with flow diverter, then we shouldn't get frustrated at 6 months if we do not see a complete closure of the aneurysm. It may take a long time for the flow to be remodeled, as in this patient. This was one of the first patients that we did with flow diverter. Because of the angulation, we were unable to put a wire in this particular patient to do dual stent assisted technique, and the patient did not want to have any open surgery in this patient. In this case, and we put a flow diverter. At 6 months, it was rather frustrating. The aneurysm is filling and the superior trunk is not filling. We kept on clopidogrel. At 12 months, the superior trunk started to fill again. The aneurysm got smaller, but still filling. But after discontinuation of the clopidogrel at the end of the first year, at 18-month control, it has the class 1A occlusion, complete occlusion with the superior trunk branches patent. A very nice result. So Instead of doing a very complex treatment or an open surgery, why not doing a flow diverter treatment in such challenging cases? Another example, in the 6-month control, because of its tortuous course, you can call this a remodeled bifurcation, a class 5, and at 18 months, it has remodeled even more, and at this point, it became a class 1B, which means complete occlusion of the aneurysm with the branch reduced in size. So it is not something very solid, it just describes the findings. Another controversial example, this is the aneurysm. A flow diverter was placed, very ugly looking nipples, several nipples, and the branch is coming off from the sac. A FRET device was placed. There's a clear-cut healing reaction here. And when you may say, well, there's that aneurysm remnant. However, when you do 3D angio, you realize that it is the continuation of the vessels. So it is a remodeling. So it's a class 5 occlusion. We also used flow diverters in recanalized coiled aneurysms when needed. When we look at the publications regarding the flow diverter treatment, at the beginning, like ourselves, Limoges group, our good friend Dr. Mounier group, they also published very promising results with flow diverter treatment in MCA aneurysms. Dr. Conyard group, they published a promising result, a good result too. Although you may say, well, there's only 1/3 complete occlusion. They have only 3 to 4 month control in the majority of the patients. Only 4 out of 13 has longer than 3 months control, but there's no mortality, morbidity in their series. Dr. Linfante published 6 MCA aneurysms, 5 having follow-up with good results, as well as Briganti. However, lately, Dr. Moret group published rather discouraging results, saying that flow diverter is not good for MCA aneurysms, with a 21% of procedure-related permanent morbidity and only 60% of complete occlusion. Therefore, we decided to do another study with the Limoges group, looking at all the MCA aneurysms done in both centers. The cases were gone over, and overall 63 aneurysms up to that point were taken into the study. And in that group, we don't have any mortality. We have permanent neurologic deficit of 3.4 only, and total occlusion rate with long-term follow-up patients is close to 98%. So if you take the remodeling into account as well. So it depends on how you look at it. It's a different concept. It is not like black and white. So it's a new concept. So you cannot compare it with the coiled aneurysms. My last slide, why are the results are different in addition to the conceptual change? Well, there are some tips, there are some specific features of flow diverter treatment in MCA. What are these? Most importantly, effective anti-aggregation with light transmission aggregometry testing is a must. You cannot rely on giving clopidogrel and not testing, or
Clopidogrel itself, even though you do testing, we know that it does not have a stable response. Some patients, if you do testing this morning, you may see a good result. Next day in the afternoon, we have such examples, you may see a low response. So it is kind of undulating in some patients. So it is better to to rely on a more reliable drug, more potent drug. And we are using prasugrel in the last 3 years almost routinely, except for very old patients with ischemic injury in their brain. And prasugrel, we have very few ischemic events, if any. We intentionally oversize the device in MCA, at MCA bifurcation, especially if located at the convexity, the aneurysm is at the convexity, so that we will enlarge the holes of the device. It is very crucial. And please do not load the device while placing, so that the mesh would not get too tight. And we try to avoid covering the bifurcation with more than one device, as most of you probably do anyway. And please do not be timid to do PTA at MCA aneurysms. If there is any any unopposition or any reduction in the caliber at the site of the aneurysm, please do PTA. It changes the patency of the vessel. So it is very important at MCA. It may be forgiving in sidewall aneurysms that you may not do PTA, but at MCA, if there's any question, do PTA. And we always keep the patient at the table to observe how the flow changes for at least 20 minutes to see if there is any abrupt change of flow, which will, with no collaterals coming. So we do not want abrupt flow change at MCA bifurcation. It may be nice to see at sidewall aneurysms, but not good at MCA aneurysms. And most importantly, be patient. It takes longer time than sidewall aneurysms. So we say as the last word, treatment with flow diverter is indicated in selected complex MCA bifurcation aneurysms, not necessarily small, round-shaped, regular coilable aneurysms, but for complex aneurysms, it's a good option, good alternative. And if you pay attention to the rules, you will get good results if you are patient enough. Thank you.
Sure, excellent. Thank you. I wanted to ask you, so when, and the rules of the MCA bifurcation, which branch do you pick? Do you think about the branch, is it purely the anatomy, or it has to do with the territory also? Do you look for both? And the other thing, the coiling, is there a size that you decide to add coils to the aneurysm, or no? Like, say, if you have a 20 millimeter MCA or a 15 millimeter, does it make any difference if you place coils or not?
Very, very good questions. So I'll start from the last. We put web in some patients as an adjunctive device to flow diverter. If the aneurysm has, for example, nipples, that we worry about the time period which we need to the aneurysm get remodeled and get occluded. However, we usually do not put coils. We worry about sending emboli to the branch jailed. That was the reason, because you jail one aneurysm, that the flow should go through the device. So we do not, I don't remember any case that we put coils, even though the aneurysm is large. But we put web device in some cases, ugly looking aneurysms. Number one, which branch we pick? Usually we pick the most straightforward one according to the geometry. Instead of making a abrupt turn, we prefer to have to place the device to the straight one so that it will behave as a sidewall aneurysm. That's one question. However, the vascular territory is also important, such as, for example, at right MCA, we try to put the device in the superior trunk because inferior trunk, we do not worry about that much. But at the left, both trunks are important. So we pick according to which one is more safer in terms of placement and which one is bigger, so that, you know, depends mostly on the angulation though. Is there anything else that I forgot? No, okay.
Okay, and thank you for your presentation, but I think you are too many cases, you don't need the flow diverter. I only use the flow diverter in a special case. And in middle cerebral arterial bifurcation, aneurysm, I think is not a good indication because sometimes you are a thrombus in one branch or you are regrowth to the type 5.
It is not regrowth. It is not regrowth. Type 5 is not regrowth.
No. Okay, no regrowth today. Maybe in 10 years regrowth.
At the moment,
No. I remember when I started with the GDC coil, the remnant neck, no regrowth. You are the patient.
Coiling is different than flow diverter because flow diverter provides a, how to say, barrier to the flow in a stable way. However, with coiling, it hits all the time. So you never know, and it may be eccentric. So it's a different issue. So we cannot compare apples and pears.
Yes, but why not to use the standard stent is possible to canalization the sac of aneurysm. When you put one flow diverter, it's impossible to go inside the remnant or the rest of the sac. I think for me it's contraindicated the use. No, it's my opinion. Another doctor have another opinion. It's contraindicated when you are the bifurcated aneurysm. You are 2 or 3 branches very close to the neck. I think it's not good. Only you have the possibility in the complex aneurysm.
Yeah, most of them I showed are complex
only
aneurysms.
it's possible to put one coil in the branch, or maybe this branch is open, and you are the possibility to test occlusion test, anatomical test. Why not to put on flow diverter, but before deploy this flow diverter, you are another catheter in the branch, or you see maybe is the point of the recanalization.
If you can catheterize easily to test for the occlusion, I mean, to do the occlusion test, so why not go ahead and do stent-assisted coiling? So there's no meaning that you do flow diverter, then I agree. However, many of the cases that flow diverters are placed are the ones that we consider that doing stent-assisted or balloon-assisted coiling would put on more risk to the patient than putting a flow diverter. Because our experience with flow diverter at MCA is acceptable, at least for us.
But it's acceptable, but if you are a recanalization, it's not acceptable.
There is no I have not seen any case so far, and we have been doing MC aneurysms for more than 5 years. I have not seen one single case that remnant, according to you, remodeling according to me, got bigger in the follow-up. That's why at the moment we are claiming this. We were not saying this 5 years ago, but now the more we see, the more we convinced, we are convinced that it behaves differently than what you see as a remnant from a stent-assisted coiling or from a balloon-assisted coiling, because it is totally different. It changes the anatomy.
Matsumoto, what do you think? From this, is your indication of a flow diverter in the middle cerebral artery for you, is that a good indication?
I'm sorry, I checked my email. Sorry.
Actually, we are not claiming that. We are still doing many MC aneurysms with standard, so-called standard methods. Although for many of people, double stent-assisted coiling is not a standard method for MCA as well. But we believe in stent-assisted reconstruction of MC aneurysms too. But anyhow, these are rather challenging aneurysm for other techniques as well. So I would like to hear about what where is the arrow? Okay. For example, in this particular case, Luis, the very first on the right side at the top. Where's my arrow? Okay. Anyway, the first one at the top, right top. I think it may be challenging for any technique. So I think having an option as a flow diverter at MCA bifurcation is nice to have. Yes.
Any experience with placing on the difficult branch a low coverage stent, self-expanding device, and on the easy branch flow diverter? So you're doing a Y, but one side of it, so you're basically crossing the low coverage with the flow diverter, because that could
then I will worry about the crossing point. At that point, the flow diverter may not open up properly.
Yeah.
That I would worry about.
I think that it may be possible with open cell or the device.
Even with open cell. And on the other hand, as Louise already mentioned, if I could do dual stent assisted reconstruction at MCA bifurcation, whether with open cell, then why not do dual stent assisted coiling, because they have better results with single stent assisted coiling, very good durable results. So, and you can retreat if there's any regrowth, it's okay. I mean, so I think if I can do stent assisted coiling with without taking too much of risk, then I would do that. Instead of waiting for the flow diverter to work for at least 6 months.
But you can see a future that, like with Pulse Rider, for example, or Web, or Medina coils. I mean, these devices that were developed for bifurcation associated with a flow diversion, for example, because to protect the other branch, that the issue said that if you have a giant aneurysm, partially thrombosed, MCA, in the carotid artery, most of us would say you have to coil and flow divert. And the MCA is no different. There is a risk to delay the hemorrhage, perhaps. But so if the concern is thromboembolic to the branch that is not protected, so how can we protect that branch, maybe? Now, I'm just thinking, what is the possibility that we could have in case of these more difficult aneurysms like that?
Yeah, with partially thrombosed giant aneurysms, there may be questions. And with the other devices, which would be available in the future, we will see, of course. I cannot foresee the future at the moment. I'm talking about the current situation, actually.
To turn back the remodeling issue and certain aneurysm, actually it is coming from Coanda effect of the fluid. And that there's some effect of the parenchyma, and also the flow is modifying everything. And it is the same thing happening in a giant aneurysm. We are seeing time to time after flow diversion, there is a kind of serpentine type of new lumen appears in the partially thrombosed sac. There was no vessels like that at the beginning because of the changing the hemodynamic factors, which is oriented by so well-known Coanda effect. It is kind of an engineering technology, and it creates as if a new river. It is different than the winter time and spring time. It is happening on the valley. In the nature is the same thing, that the river place is changing due to the flow amount. For your classification of 5, it is so obvious that the remodeling of that, the arising vessels and the size of that arising vessels on multiple factors, not only the flow, the sump effect. It may affect, it may also reflect why we are having a 1 occlusion, a COMP, or P1 occlusion because of the PCOM.
Exactly, exactly. I said that before. I mean, flow demand is the determining, one of the determinants, actually. Sorry.
Congratulations for the talk and for the results that you have and that you have showed us. But the thing that I was thinking, you saw that 6 papers talking about this kind of treatment for these aneurysms, and there's only one with big complications, the one written by Moret. And I think that people that we don't usually do this kind of treatments, what I think it's, what do I have to do to not have those results?
Yeah, that's
those
what,
are the recommendations that you already taught.
yeah, that's what I'm saying. There are very strict rules in our, at least, mind that, for example, we do not use clopidogrel because we rely on prasugrel much more than clopidogrel. Clopidogrel has a unstable response in some patients. I have and some of my friends have very bizarre experience with clopidogrel testing today and then the day after tomorrow, you know, today, I mean tomorrow, and seeing very different results despite that the patient is in the hospital and getting the drug with no additional drugs to interact. So we know that clopidogrel does not have a stable response in every patient. So we believe in prasugrel as a single device with no aspirin, only prasugrel. That's one of the issues. And regarding how we determine the result of the treatment in terms of closure, you need more time than regular flow diverter treatment. For at least 1 year, sometimes up to 2 years. You may say, well, this is too long time and the patient may have a bleeding in that time period. So far, we have not had any example of that. But of course, it is not a guarantee. I understand that. But it takes longer because there's a flow demand that there should be flow through that aneurysm for sure at the bifurcation.
I'm neurosurgeon, so I have a different opinion. Such large, giant thrombosed MCA aneurysm are good indication for single or double STA MCA anastomosis surgery following distal MCA clipping. It's my opinion.
I'm not sure I could follow. Would you please repeat it again? I couldn't hear well.
Oh, okay. For such a difficult MCA aneurysm, good indication for single or double STA MCA anastomosis following distal MCA clipping.
In our series, we don't have any joint aneurysm. Well, one in the border, a big aneurysm, more than 2 centimeters, but not like a real giant with partial thrombosis. It may, the parent artery occlusion may be a better solution for such aneurysms that we worry about the rupture as we have in ICA giant partially thrombotic aneurysms after flow diverter, then you may need bypass surgery. However, bypass surgery has its own risks, has a relatively high morbid mortality. So would you please tell me the morbid mortality rate of bypass surgery on regular?
In our hospital, our hospital is the corner hospital is less than 3% morbid mortality.
In the literature, it is as high as 10%. So bypass surgery is not any easier than or any safer than endovascular, at least to my experience.
Of course, we know the morbid mortality rate is depend on the skill of the surgeon.
Well, it is true for every procedure, every surgery, every intervention. The other one? Yeah. So, can we put the other one? Let me put this.
Okay.
Yes. Now I'll present our experience with joint aneurysms with reconstructive treatment. So I do not include the deconstructive treatment, which is parent artery occlusion, which may be a good way of treating the patient in selected cases. This talk does not include the deconstructive treatment alternatives. In the last 20 years, endovascular technology and neurointerventionists have been struggling to create more effective and durable endovascular reconstructive treatment options for large joint aneurysms after failure of coiling had been realized in this particular group. The treatment target of such reconstructive techniques is not only treating the sac, but also the sick vessel wall adjacent the aneurysm neck. You see the techniques, reconstructive techniques, in a chronological fashion, starting with old-time balloon expandable stent and coil reconstruction, and then onyx was introduced, be used in large and giant aneurysms with great enthusiasm. At the meantime, covered stent was an option, and then we started to have neuro-dedicated stents, starting with Neuroform Wingspan, then Solo Enterprise, Solo Solitaire, and then stents got smaller profile that increased the safety and durability. And as another concept, flow diversion came into our practice, first with so-called homemade techniques with regular stents, and then the dedicated flow diverters were developed. So I would show examples and advantages, disadvantages of the techniques. This was a case that we treated with balloon expandable stents many years ago with coiling, and the stent and coil reconstruction reduced the regrowth rate dramatically from almost 100% in giant aneurysms. It was almost for sure that the coiled giant aneurysms will come back with recanalization. So we were very happy with the stent assistance. However, stent assistance does not guarantee that it will be durable. So almost 1/3 of the giant aneurysms recanalized despite the use of stent, as in this particular patient, for example, recanalized twice, and after the third retreatment, we put a flow diverter inside the previous stent to have a more durable result. Onyx was a great introduction at those times, and we realized the parent artery reconstruction with the help of the liquid. Nothing else made this reconstruction before, so we were very happy and excited. However, even with such a reconstruction, it showed recanalization in many of them when onyx is used alone in joint aneurysms. Only 1/3 of the joint aneurysm stayed stable with balloon only in the onyx treatment. Stent onyx reconstruction technique has certainly created the best durability results of all times. We did not have any recanalization in stent-assisted onyx technique in our series. You see the long-term follow-up in one of them, in another one. Onyx was used with coils as well. However, it showed some recanalization in some patients. But or stent plus coil plus onyx as a combination, it worked very nicely as well. For example, in this patient, we first coiled the aneurysm, including that small portion as well. And then for the giant part, we put the onyx, and in order to make it more durable, we place a stent. And it was good enough that it did not show any recanalization in the long run as well. Here it is only 1 year control. And with the giant aneurysms, bypassing is an important issue if you are to put a stent or if you are to do onyx technique, because you have to bypass the neck. And we described at those times balloon-assisted loop technique to bypass a giant, complicated wide neck aneurysms, that you make a loop and go distal. Oops, sorry. And then inflate the balloon so that it will stable the microcatheter, and then pull the extra length of the catheter wire combination so that it will cross the neck. But nowadays, we do not need to do such fancy maneuvers, because first we switched to Mirage micro guide wire combination that you can straight this complex very easily, don't need a balloon. And then with the help of the smaller profile microcatheters, soft microcatheters, like the Headway Duo microcatheter, you can do it very easily. You can do your loop, go distal, pull the wire, then pull the extra length, and you can bypass. But at those times, it was a good trick for the neck bypassing. In the meantime, covered stent was an alternative. Of course, covered stent is not for all locations, for all patients. This was a post-trauma patient presented with nose bleeding, a giant dissecting aneurysm, and covered stent was an excellent tool in such location that as soon as you placed it, you eliminated the aneurysm. And this is the 15-year control CTA on this patient. the calcification at the wall of the shrunken aneurysm and the luminous patent. Another patient treated with covered stent, but look how straightforward the proximal is. In order to navigate a covered stent, if there is proximal tortuosity, then it is not easy. It's a stiff system. And also you cannot place it where there's an important sidewall branch. So it has its own limitations, but especially for traumatic cases, it's a very good tool. Another covered stent experience. Again, for the bypass, the balloon loop technique was used. And then the neuro-dedicated stents came out, and it changed our practice very much. We do stent-assisted coiling. We do double stent-assisted coiling. Some are, especially the dual stent-assisted coiling, they are more durable because you change the flow at the same time, not only create a barrier for the coils to stay inside or to reinforce the neck, but also if you use dual stent, it changes the flow. With lower, then came the smaller profile stents, and for example, in such a large aneurysm, it was possible to wire those branches and create a wide Y reconstruction and then coil the sac with a very stable result. Stent-assisted coiling, this time it was a solitaire, despite that it's a stent with body. We know that joint aneurysms may get recanalization. Homemade flow diversion techniques we started to use in selected cases. Before going further, I would like to share with you some numbers to give an idea about our cohort that our intracranial stent experience for the 20 years, starting with balloon expandable stents. We treated more than 2,000 cases overall, of course not the giant ones. Even balloon expandable stents were used more than 100 cases, and flow diverters and homemade flow diversion were used close to 900 aneurysms. And these are the numbers just to give an idea about our cohort. Our experience is more with pipeline among the dedicated flow diverters. Actually, we found out the effect of stents with some accidental cases, I would call. In this patient, balloon expandable stent was placed. However, after that, we were not able to go through the mesh of the stent into the aneurysm, that it started to move the device. So we left, and we thought that if we leave for a few weeks, then it will maturize and we would not push the stent into the aneurysm. And when we call back the patient 1 month after to coil, please note how the angle of the artery has changed with the device, as well as how partial thrombosis happened in this particular aneurysm with a balloon expandable stent. So we realized that sometimes stent itself may end up thrombosis of the aneurysm with the change of the geometry. or maybe with some additional factors as well. With that leading point, creating a new concept in the endovascular treatment, telescope stenting in selected cases was the first step before reaching the real revolution of the dedicated flow of diverters. We used this technique when the patient presented with mass effect, because if there's a mass effect at the brainstem, then you may aggravate when you deposit coils into giant aneurysms. It happened to us in few patients, unfortunately. So we did telescopic stenting in such patients where there is significant mass effect, symptomatic mass effect on the brainstem, especially in the posterior circulation. This was 2 Enterprise 1 Solitaire. Please note how the angulation of the vessel is changed, and this is only 6 months control, and this is 8 years control on this patient. It's a very good result. This was a live workshop case that 4 devices, 4 stents were placed at the same time. It had mass effect and edema within the brainstem, and post-treatment 9 months control, of course with the steroid as well, but please note the size change of the aneurysm with stents only. And this was the remaining part filling and partially thrombosed, and there's a small filling except for that, and the patient is still under control with no symptoms. Another example, 2 telescope Leos, mass effect on the medulla oblongata, and look how nicely it remodeled, and there's only a little bit of filling here, but please note how much the aneurysm got shrunken. In this patient, because of the mass effect issue, we did Y stenting only at the beginning, and this was the follow-up after the Y stenting flow diversion only, and then we coiled the remaining sac, and this was the 6-month control on this patient with the aneurysm occluded and no mass effect. And this patient has long-term follow-up as well. Real revolution is flow diverters, dedicated flow diverters. They were originally designed for large and giant sidewall aneurysms and dissecting fusiform aneurysms. And in such aneurysms, one putting flow diverters only provided very, very good results. We were very happy seeing such results. For example, this particular patient presented with vision loss on both sides, starting unilaterally at the beginning. And in 1 month control CTA done for our curiosity, basically, because these symptoms improved significantly, and we want to see how the aneurysm is doing. Despite that the aneurysm is not filling, please note that the mass effect on the A1s is still there. So the aneurysm is still there. However, it is not filling anymore on CTA. And on the long run, the mass effect is gone as well. This is the 2 years control. I have the angios as well, and this patient is cured. Another example, again, just to show, this is the 5-year control MR showing that the aneurysm disappears. So in the giant aneurysms, large giant aneurysms, the angio findings is not followed by sectional imaging. Sectional imaging comes from back. I mean, they come later. So don't get upset if you do not see the resolving of the mass itself in the first control at the same time with the angio, which shows complete occlusion of the aneurysm. If the aneurysm is really got complete occlusion, then in the follow-up, it gets smaller. There are anecdotal cases in the literature showing that the angio did not show any filling of the aneurysm, but the aneurysm kept getting bigger with the vasovasorums of the aneurysm. However, there are anecdotal cases. So in the majority of the cases, if the aneurysm got occluded 100%, then the mass will shrink down. Another example, flow diverter. We have a very good stagnation. At the beginning, we were very happy with those stagnations, but then we realized that how dangerous it could be, that intraneurosmal clot and its inflammation. We were aware of the inflammation effect of the joint aneurysms after the treatment. This was a case treated with covered stent, and after the covered stent placement, it was perfect mechanically, angiography was perfect, but the patient was not. The patient had severe swallowing problems. We needed to put gastrostomy. The patient was hospitalized for a few months and then started to recover after a while. And at 1 year follow-up angio and MR, it was okay at the end, and the patient was totally asymptomatic after the anti-edema and anti-inflammation treatment. However, we knew how the inflammation may cause edema and how it can cause problems, but we were not aware, we could not predict that this problem could go even further. This was a very unlucky case for us. We put flow diverter in this patient, and there was a stagnation of the flow immediately after the flow diverter. It was only single device. Post-op 4th day, the patient started to have headaches. The patient is already on steroids, full dose steroids. And post-op 7th day, she started to have severe headache. There is thrombosis of the aneurysm. And post-op 10th day, she had a very severe subarachnoid hemorrhage that the patient died in the following days. And the CT angiography at that time did not show any filling of the aneurysm. And how can we solve that problem? We have different solutions for the intraneurosmal clot and its inflammation after flow diverter treatment. How about coiling? So we started to advocate coiling with giant aneurysms, but then comes the question, how much is enough? How many coils? We do not have any patients in our own series who ruptured despite coiling in addition to flow diverter. However, this was one of our friend's patient. It was really, really very discouraging. He coiled that much. I mean, how much more that you could coil, and then put a flow diverter. Flow diverter plus this much of coiling. Still, after only 18 hours, the patient had a big time rupture and died. So even with coiling, even you stop the flow, with giant aneurysms, unfortunately, there is no guarantee that, at least I am aware of, to avoid rupture. And it is very frustrating because many of these patients, they are unruptured patients. You treat to avoid the risk of rupture, and after your treatment, the patient has a rupture. So, and mostly they end up fatal. So it is very, very discouraging in giant aneurysms, that post-treatment rupture issue. In our 800 aneurysms, we had 4 early post-treatment subarachnoid hemorrhages. 3 of these 4 were giant and supraclinoid IC aneurysm. And 78 out of more than 700 aneurysms, they are giant, so 78 giant aneurysms. And in 49 of them, we put coils. In none of the coiled ones, we do have rupture. The post-treatment bleeding rate, if you calculate, in giant aneurysms, go as high as 4%. If we take only supraclinoid IC aneurysm, because you do not expect a extradural aneurysm to rupture, that giant aneurysm cohort includes extradural giant aneurysms as well, for example, cavernous aneurysms. So if you deduct those as well, 3 out of 42 makes 8% of post-treatment rupture, which is really a significant number, a significant risk. So what are the other solutions? One, that some doctors advocate putting many devices inside each other so that there will be no flow into the aneurysm. But it's rather an expensive method. What we found out in our own experiences, we staged the treatment. We ended up in this, after seeing the ruptured giant aneurysms, mostly, we palliatively coiled the aneurysm. And then after 1 month, 2 months, not too long after, it gets regrowth anyway. Then we put the flow diverter, not at the same stage. In those groups, we do not have any rupture. Of course, I cannot say that it guarantees that it will stop the post-treatment bleeding, because we don't have any bleeding in our adjunctive coiling with flow diverter in the same session group as well. But at the moment, this is what we are doing. So we stage the treatment in especially high-risk group, which are a high aspect ratio in the parophthalmic region with a straight flow into the aneurysm, relatively narrower neck, etc. Looking at our flow diverter experience, we used flow diversion, dedicated flow diverters in only a small group of posterior circulation aneurysms. And mortality, this is overall, just to compare with the giant group, actually. 2% mortality and around 2% permanent morbidity, and complete occlusion rate is over 90%, and at 5 years it may go up to 96%. But what is important is morbid mortality occurs more in the posterior circulation aneurysms. 31% morbid mortality. 31% of all morbid mortality occurred in the posterior system aneurysms, where the posterior aneurysms only comprise the 9% of the entire group. So at least in our series, the risk is much higher in the posterior circulation aneurysms. And Jivan will talk on the posterior circulation aneurysms anyway, so I will not go in detail in that. But our mortality in the posterior circulation is around 9%, whereas overall it's only 2%. And in the telescope, we prefer dolichoectatic aneurysms are a different kind of story. the joint aneurysms. Yes, it's a joint aneurysm. It is partially thrombosed, but it behaves very differently than segmental involvement. So most of the time, we treat such aneurysms with telescoped stents. However, they have very poor prognosis in our series, actually. However, in the posterior circulation, for example, in this location, not in the distal half of the basilar artery, if it is segmental involvement, a focal lesion, even though it is that big, with the flow diverter, we obtain a very good result. However, in the other group of aneurysms, dolichoectasia causing joint aneurysms, even though you treat in the angio very nicely, very good results in the follow-up angio, both patients in the longer run ended up getting symptoms again and died eventually, those two patients. In the so-called short period of time, they did fine with the telescope stents, very nice angio result, but they died. So since Jiwan will cover these issues, I'm not going to go over it. These are the larger MC aneurysms close to giant border that we treated with flow diverter. I showed this already. And this M1 aneurysm, giant partially thrombosed M1 aneurysm, and this is the 5-year control. This is the origin of the lenticulostriate branch. So only the origin of the lenticulostriate branch is filling, and the patient is still doing fine. So it is also, the flow diverter is also a solution for giant aneurysms where there are branches coming off the sac. In our experience, we treated 242 giant aneurysms with reconstructive techniques. This does not include parent arterial occlusion, all kinds of techniques. Overall mortality is more than 5%, morbidity 12% in that particular group. It is worse in, as I said, it is much worse in the small group of patients with dolichoectasia. And last word, deconstructive treatment, so-called parent artery occlusion, may be the best option for some patients, as in this particular patient. This patient had very good collaterals that we did parent artery occlusion, and the control MRI 1 year after the parent artery occlusion, the aneurysm shrunken down, and the right temporal lobe is showing encephalomalacia, but we don't know how it looked like before, if this is a traumatic dissection and this is the result of that trauma, or if it is because of the parent artery occlusion, or if it is because of the mass effect compression. Anyhow, and surgical bypass with parent artery occlusion is the last option, at least in our practice, for the giant aneurysms where we don't have any other option feasible. Thank you for your attention, and I would also like to encourage the people for applying to grant, because there's a grant for our WLNC meeting in LA. Please check the website and apply for the grant. Thank you for your attention.
Fivan. Now, okay. I discuss both, okay? Yes. Any question to the Professor Isil? Isil.
Yes.
Whether you, maybe the the rupture after deploy the early rupture of the aneurysm is maybe is due secondary to manipulation of the micro or the devices in the neck or in the. Do you think, or the case where you are the rupture is very easy to navigate with the flow divert?
Well, for example, the one that I showed, who died after the placement in the posterior circulation, it was a very straightforward case. And the patient ruptured at the 10th day, for example. So I believe that, I'm sure people have similar experiences. It may happen even in patients where you don't have any difficulty at all technically. So there are, of course, cases, especially in the learning curve, that you may have bleeding after the treatment because of wire manipulation or whatever. But giant aneurysm rupture after flow diverter placement cannot be only attributed to the technical issues. No. That's what I'm saying.
I totally agree, because I have one case here in this hospital with the Church-Strauss syndrome. Is very complex aneurysm, bilateral aneurysm, and is rebleeding 10 days later. Is bleeding, sorry, 10 days later. And I think is secondary to change in the flow in the distal part of the middle cerebral artery, the cortical part. I think when you change the flow with your giant aneurysm,
yeah, but
and you change
it
the flow,
is removed parenchymal hematoma, correct?
Yes.
This is another issue. I didn't go into
maybe.
details because it is an issue of, in general, flow diverter treatment, how to say, complications. So I didn't go to that issue. If flow diversion is to be covered, probably it's going to be inside. That's another issue. That has its own explanations. What I'm saying is rupture after flow diverter treatment of a giant aneurysm. This is a different subgroup.
Okay.
Okay. Thank you. First of all, let me thank to Luis for inviting us for that beautiful city, which is one of my favorite in Europe. We hope that we're going to enjoy it a little bit. And then my topic will be the flow diverter treatment in posterior circulation aneurysm. Here are the disclosures, and then here are well, first of all, we need to clarify certain things, because there are some young generation neurointerventionals in the room. For them, we have to clarify certain things. The first, what we have seen in angiography has nothing to do with the wall of the artery. All we see is just the lumen, right? Because after the lumen, what we see is that there is a vessel which has a wall, a certain thickness, and then when we have to cut the vessel wall, we see a change in the diameter of the wall in different part of the artery. It's called a plastic deformation. Plastic deformation means that when you load any material to a critical point, and then if you reach the critical point, even if you unload the load, the material will show a permanent deformation. It's called the plastic deformation. This is important to understand. And also, when we do the flow diverter treatment, it's a pure hemodynamic treatment. What we do, we try to change the flow in the lumen. And by changing the flow within the lumen and within the sac, what we are trying to do is that either we are trying to reach a critical threshold for the flow, which will trigger the thrombosis within the aneurysm sac, which is one way of occluding the artery, the aneurysm sac. The second one is that since this is a biological environment, upon changing the flow within the sac, we may reverse the plastic deformation. If we reverse the plastic deformation, then, as Ishil showed a lot of examples, the sac will exhibit a different way of behavioral. Rather than enlarging, it will become to shrink. It may shrink fully, or it may shrink partially. It depends upon the flow environment of the residual sac. We got to understand this. Then it will be, here you see that there are before and after flow diverter treatment, the color of the velocity vectors within the sac is different, meaning that now the velocity is lower. And then if it's as low as the threshold, then we will see the thrombosis of the sac, which is a good thing, but also a very awful thing, because the clot may emit some sort of chemicals, some enzymes that may rupture the aneurysm. This is some different story, okay? Now, that's why if we, for example, take a P1 aneurysm like this, you may see a thrombosis type of healing. You don't see any filling of the aneurysm, but still the aneurysm is there, and then the sac is filled by the clot. Or, as this sidewall aneurysm, you do a flow treatment, and then the flow treatment let the biological tissue reverse the plastic deformation. As you see here on the MR angiography, there is no residual sac at all, because all the tissue which has gone through the plastic deformation, now it's retaken the original position. Okay. After having said that, the posterior circulation aneurysm is our today's subject, but they are totally different than the anterior circulation aneurysm, because the so-called unusual aneurysm of the posterior circulation is far more frequent than the anterior circulation. What I'm trying to say is that they may be fusiform, they may be dissecting, they may be degenerative, it's a different story. Therefore, for example, here probably more than half of the cases a non-saccular aneurysm of the arterial wall. Therefore, you may see, you may see a non-segmental, fusiform, partial thrombosed aneurysm of the basilar trunk, which is absolutely a non-saccular aneurysm, or you may have a dissecting aneurysm, which is another story. Therefore, you may see some sort of aneurysm, and the sac of it will give off certain branches. Although it may appear a saccular aneurysm, in fact, it's not. Because whatever treatment you do, you gotta keep all those branches patent. And then when you do the treatment, you do not expect a full occlusion of the sac. And then a part of the sac will need to stay open in order to keep the daughter branches coming off from the sac patent. Therefore, what we shall try to explain is that when you do this flow treatment for those aneurysms, you will see some sort of reversed plastic deformation, but at the end of the day, you may have a part of sac still patent, but this theoretically speaking, this should not present with any risk, because you reversed the deformation. Anyway, I'm going to talk about our experience, which is something like 40 cases. And then some of them are on the V4 segment, some of them are on the VB junction, some trunk, some bifurcation, and some PCA. As far as the indications are concerned, we may say that depending upon the type and localization, we may discuss the indications. For large and giant aneurysm, yes, provided that you do not have a better solution. For dissecting aneurysm, definitely yes, provided that you couple your treatment with a morphologic one in order to have an immediate protection of the aneurysm. Or you may have a wide neck aneurysm. There is definitely an indication. A fusiform aneurysm, This is probably most discussable and questionable part of the indication. It's probably yes, if the disease is segmental. If it covers fully the basilar artery, the chance of having a good result will be less than 50%. Partial thrombose, it doesn't matter. And VB junction, yes, as far as the localization is concerned. The bifurcation, yes. V4 segment, it's probably the best indication for flow diverter treatment. Basilar trunk, yes, provided that it's segmental. And PCA, yes, provided that you have a good landing zone and then the diameter of the vessel is large enough to accommodate an existing flow diverter. Okay, let me give you some examples. This is a 31-year-old female with extensive headaches, and then MR shows a giant basilar artery aneurysm. Here is the angiography and the 3D, which shows that something like 3 centimeters sidewall basilar trunk aneurysm. And then a couple of days later, the patient presents with extensive headaches, and then the following morning of the hospitalization, she ruptures. And then you have a patient who ruptured with giant aneurysm, and then the Glasgow Coma scale was around 6, and then you got to do a ventricular drainage, etc., etc. Then the patient recovers. Then you have to do a morphologic treatment. You got to protect the sac. That's why you do a balloon-assisted coiling, as much coil as possible. You see that partially the sac has been thrombosed, and then the rest of the sac is patent. You fill it with coil. And then after the endovascular treatment, the patient goes through the usual complication, the hydrocephalus, etc., etc. Do the VP shunting, etc. Then 3 months later, we know that the patient will recur anyway. And 3-month control angiography, 3D image clearly shows that the distal part of the basilar artery has been diseased now. There are 2 things. The first, the so-called neck of the aneurysm is covering more than 270 degrees of the circumference of the basilar trunk. The second thing is that there is a angulation of the basilar trunk. The angulation of the basilar trunk will put the so-called flow impingement zone toward exactly to the sac. Therefore, what you have to do 2 things. First of all, you got to play with the flow, but also you got to play with the geometry. How you can do this? As usual, you do a flow diverter treatment. By doing a flow diverter treatment, it's a 3-month control angiography, shows that a nice reconstruction of the basilar trunk, which is the 3 months before. Here is the model. For any aneurysm sitting on the large curve of the curvature, will have a flow impingement zone to the distal lip of the neck, okay? And then, as you see here, here is the flow impingement zone on the curved vessel aneurysm. When you change the geometry, when you straighten the vessel, then you're gonna change the position of the flow impingement zone, and then you will redirect the flow impingement zone toward the normal vessel. By doing so, you do 2 things. First of all, you diminish the flow within the residual sac, the first thing, which will trigger either thrombosis or reverse plastic deformation, or you definitely change the flow impingement zone, and then the risk of recurrence will be, okay. Another patient, I think it's in 2009, a young lady presented with these, as usual, headaches, etc. The CT shows a hematoma. It's not a diffuse subarachnoid hemorrhage, but rather hematoma within the interpedicular system. Here is the angiography. Angiography shows that the patient has it's very probably a fusiform aneurysm of the right P1 segment, right? And then the P1 segment, and then the superior cerebellar artery is originating from the sac. In 2009, the patient treated with the homemade flow diverter with 2 telescopic enterprise, and then we coupled the treatment in 2 years later with a Leo plus silk treatment. Leo plus silk is used simply because, first of all, I put a silk within the construct. But when I put the silk within the construct has become little more stiffer, and then created an angulation of the basilar trunk, where immediately after we saw the development of the clot. That's why we got to change the geometry. That's why I put the second flow, the second Leo at this junction in order to make a smooth transition from basilar trunk to the distal basilar artery. 4 years later, or 2 years after this flow treatment, still the same. You have two pouch, one is upper. The upper pouch does not give off any branch at all, but the lower pouch is giving some sort of superior cerebral artery origin, okay? And then 2 more years later, now you see that the upper pouch is gone because there is no need to stay there. It's now a healing, is a reverse plastic deformation, but the lower pouch will stay there because the superior cerebellar artery is sucking blood from that sac. Whatever treatment you do not lower the flow as low as to trigger clotting, okay? The territory of the superior cerebellar artery is large and dependent upon this pouch. Therefore, this patient will stay like this. But it's a stable treatment. Although you may say that there is a residual aneurysm, it probably does not create any risk for the patient. Okay, dissecting type is a 17-year-old boy, actually is a son of a pulmonologist, and then the patient ruptures, low Glasgow Coma scale, the drainage, and then comes to our attention. It shows a sidewall dissecting basilar aneurysm that we have to do a morphologic treatment, meaning that we gotta close the sac with the balloon remodeling. But even if we know that there is a small, some dimple at the end of the treatment, it's gonna come back, the sac. Here, 9 days later, only 9 days later, the aneurysm is come back, and then control angiography shows that the coil that we placed previously has been pushed away from the parent vessel, and then there is now a opening of the lower part that we had to close with coils, and then we need to couple the treatment with flow diverter. We try to take as much possible as the normal basilar trunk, hoping that the dissection may be well beyond the neck that we see on angiography. Okay, but 3 months later, the kid came back with some blurred vision, and then the control MR shows that, first of all, there's a large sac, partially thrombosed, and then perianeurysmal edema. And then CT angiography that you see on the left lower corner shows that there is a filling of the sac. It means that the sac is patent. Here is the angiography. Angiography shows that there is a jet within the sac of the aneurysm. The coils have been pushed away. The only thing that we could do, put another flow diverter here is a pipeline, and then this is after the treatment, okay? 3 months later, MR shows that, first of all, the sac is shrunken, and now there is no filling of the aneurysm, and then angiography clearly shows that the coils that we had put previously has been turned back to their original position because of the shrinkage of the sac. And also now we have a nice patent basilar artery, it does not show any sign of dissection. That's why for the dissecting aneurysm, doing a flow treatment coupled with some sort of morphologic component like a coiling is a very good idea. And then I believe that there is a very prominent indication for flow treatment. For the segmental basilar trunk, right? This is another story. The patient presents with the signs of hydrocephalus and headaches, and then you see that there is a hydrocephalus, and then the prepontine cistern, there is a large aneurysm. In Jarapasha, what we do, first of all, we shunt those patients with adjustable shunts, and then we do a posterior fossa craniotomy in order to keep a place for the aneurysm. And then afterwards, we do a flow treatment. But do not forget that this is a segmental disease. Since it's segmental, after the flow treatment, a year later, you see a perfect reconstruction of the basilar trunk. We may expect this type of result provided that the disease is segmental. If the disease covers fully the basilar trunk, it's another story. Here, another example, it's a sidewall aneurysm that I've already shown, and then the angiography will show there is a very nice reconstruction of the basilar artery. Here is the problem, right? 24-year-old boy, bedridden, aneurysm for years now. Nobody did anything to him. Probably it was not possible at all. But now the patient, the family is seeking something, right? And then there is no PCOM. Therefore, there is no way to do a deconstructive treatment. We do not have a surgeon who could do a occipital to PCA anastomosis. Therefore, the only option that we had after having discussed with the family was to do a flow treatment. As usual, place a VP shunting because the patient will be on a double antiplatelet for a long time. Therefore, this will probably prevent having a surgery. We do everything before: posterior fossa craniotomy, VP shunting with adjustable shunt, and then try to reconstruct the basilar artery. Here, there are several devices, but not because they are telescopic fashion, but rather in order to have a long construct, I had to put, I think, 11 thread here. Okay? I even tried to rationalize this treatment by doing some flow studies with Philips, And after having done the flow studies, the amount of reduction was not good enough. That's why we decided to occlude the right vert. And then the following day, we took the patient back to angiography and closed the distal part of the contralateral vert with the UNO device. Nice. And after this device, as you see that in the corner, there is something like a 58% MAFA reduction. We thought that it's not so bad. Let's go with that. And here is the angiography. Angiography nicely shows that within the aneurysm, you see the jet of the flow within the construct. We were happy. Here is the MR immediately after, just a week after the treatment. There is no perforator occlusion yet. The patient was not so bad. Then the patient began to deteriorate. First of all, due to the perianeurysmal edema that was treated with steroid, etc., but he never ever recovered again, right? Although the MR showed the total thrombosis of the aneurysm, except the lumen of the flow diverter, the patient did not show any, recovery. And then we sent the patient back to home. And then a year later, I received these images from the father that the patient ruptured a year later. Although the aneurysm appeared to be occluded with clot, nonetheless ruptured. We may discuss it later on. This is, for those aneurysms, the chance of having a good result is probably less than 50%. Here you have another type of aneurysm at the basilar bifurcation, once again bilobed, and then some part of the aneurysm sac is giving birth to the daughter branches, PCA and then superior cerebellar. After having done with the flow treatment, you see that action of the flow, but not here. It's immediately after, and this is 9 months later. What you see is that some part of pouch has gone away because that part of the pouch is not feeding any of the branches, but the other part, which is feeding the superior cerebellar artery, is still patent. Although it's smaller now, the sac has shown some sort of reverse plastic deformation, but nonetheless, it's still patent. Very probably, although this, on the angiography, it appears, I don't know whether you see it appears that the sac has been separated from the flow diverter on angiography, but still there is a flow, and then very probably it will take longer to change the diameter or the shape of this sac, if anything will happen. I don't know. But anyway, another place, in VB junction, ruptured patient, right? And then there is a very large neck aneurysm. the aneurysm sac is being filled by rightward and the leftward as well. And then therefore, you got to couple your treatment with morphologic one and the hemodynamic one. In order to achieve this, I put the flow diverter from left vertebral artery to basilar trunk. You see here. And then going through the rightward, I occluded the sac and the distal part of rightward. Okay, this is the angiography immediately after. And this is control angiography. Control angiography shows that the remaining part of the sac, which is lateral to the coil pack, has not gone away because we coupled the treatment with the flow one, and then we benefited the advantages of morphologic treatment plus the hemodynamic treatment. Anyway, there are several problems concerning the flow diverter treatment of the posterior circulation. One is, as usual, the instant so-called either stenosis or hyperplasia, which is not so infrequent. As you see here, this was a patient treated in 2002 with a ruptured superior cerebellar artery aneurysm, and then the patient recurred in 2015. Then we did a flow diverter treatment, but a year later, you see that the right P1 up to the PCOM is now shows a very prominent instant stenosis. I don't know whether or not it's a intimal hyperplasia or some sort of thin layer of clot, but nonetheless, it's it. Since it does not create a hemodynamic ischemia for the distal territory, there is no need to do any type of balloon dilatation. But if the artery is beyond the polygon of Willis, and then it may create some sort of hemodynamic ischemia, very probably we gotta do something like a balloon dilatation. Another patient, the P1 aneurysm, several P1 aneurysm on the left side, as you see with the 3D images, treated with flow diverter Fred. This is one of the paraphatal occlusion that we saw. Although at 3 months, the patient did not show any symptoms related to this paraphatal occlusion. Nonetheless, it happened to the contralateral side, which might be normal because we know that the basilar tip may be asymmetric and then may give rise to the branches from one side to the other side. Okay, here you see that the control MR shows total disappearance of ischemia without another big sequela on MR, and then the control angiography, I think a year later, clearly shows that there is a perfect reconstruction of the P1. Okay. Another example for the intimal hyperplasia is that it's a P1 aneurysm. It's a very short normal P1. It was quite early, I think in 2011 or something like this. We did Leo plus silk treatment. And immediately after the treatment, the aneurysm has gone away. That there is a thrombosis of the aneurysm sac, but the control angiography shows that there is a very prominent instant hyperplasia. Although the patient is free from any symptoms, there is. We will do the 5-year control angiography by the end of this year, and very probably we will see that the intimal hyperplasia, we have seen it before, will change its morphology, and then artery might look normal. Okay, there is another indication for flow treatment is the recurred or failed coil treatment. This is the patient ruptured aneurysm that I treated with stent plus coiling, and then the patient came back with the regrowth of the aneurysm. This is a partial thrombosed one. And then when we saw this angiography, we decided to treat the patient. And then this is the vertebral artery. You see that side of the coil, there is a residual filling of the aneurysm. It's a couple of weeks later when we took the patient back for treatment, we saw that this part has gone away, but nonetheless, within existing baby Leo, I put a silk stent, and then it's a 3-month control angiography, shows that the neck of the aneurysm, there is still some filling. The contralateral P1 aneurysm is now filling probably less, but nonetheless, the patient is still waiting for the control angiography. What is the saga for posterior circulation? Is there a more peripheral occlusion? little more. We got to accept this, especially for the basilar bifurcation. Is there a more major branch occlusion? No, it's something like, less than 5%. There is a rules of 5 for me for the flow diverter treatment. There's a little more than 5% ischemia, little less than 5% hemorrhage, and then something like little less than 5% instant stenosis. It's something, for the posterior circulation, this is the same. It appears to be the same. When we check the numbers from the meta-analysis of the posterior fossa, I think these numbers are very acceptable. Here is the trick for a flow diverter treatment in posterior circulation. The stent has to oppose to the segment where all the perforators are coming off. Therefore, you got to slightly oversize your device. Zones should be straight. You should not land the stent either distal or proximally at the curve of the vessel, if possibly. One has to respect the hemodynamic environment. I mean, if there is a P1 on one side, and then if there is no P1 on the other side, and then the origin of the superior cerebellar, etc., etc., it's very important that the patient will be kept on double antiplatelet for a long time, probably longer than the anterior circulation. And then when there is a need, one has to complete the hemodynamic treatment with morphologic one. We all know that these are heterogeneous group of patients. Flow diverter is just another device. There are advantages and disadvantages. But I would like to stress once again the double antiplatelet, which is needed for a longer period of time. And then we have to know where to use the flow diverters. And then we got to look in a little different way. We have now an eye of a neurointerventionalist, but we need to look the problem little bit like an engineer as well, to see the flow modification, the geometry modification, etc., etc. Okay? You are all welcome for the WLNC meeting this year in Los Angeles. We will be happy to see you. And then I hope that I try to clarify the confusion about the posterior circulation. Thank you.
Comments?
I think this is it's a difficult topic to summarize everything, but the point of can you predict today a variable degree of construction? Because when we use many times one device and you're paying attention to the points you point out, one thing that we didn't talk today is if we go into the top of the basilar versus the trunk of the basilar, do you see maybe any role to place the low coverage, longer device, and then more in the neck of the aneurysm, the flow diversion, and do a hybrid construct on purpose? Right. So I think, because like you said, like an engineering thinking about this, do we really need the full coverage all in the normal anatomy also, or should we have a device? Let's say, we talked about the dissecting aneurysm. You want to go beyond the borders of the lesion. So should we use a longer device with low coverage and one with a larger coverage in the center? Okay. I just wonder that it's not a new concept, it's an old thing, but I think it makes total sense because of the perforators and the gradual thrombosis of the aneurysm sac. Okay, then when we decided to use the flow diverter, I think in 2008 or 7 or 9, I don't know, we used to use silk, which was a very weak device, very low radial force. And then that's why we developed so-called silken Leo. Yeah, the idea was to have a long construct that will create some sort of ideal environment for the flow diverter, and then to place the shortest possible flow diverter within the device. We gave up because with the existing, there are two reasons for that. First of all, you have a
double layer flow diverter, which is something like a Leo silk combination, or you have a device with a very good radial force, such as pipeline, then because the perforator business has nothing to do with the length of the device. The problem is that you shouldn't leave any dead space between the device and the wall. When there is a dead space between device and the wall, it's 100% sure that there will be some sort of thrombosis there. And then if there is any perforator coming off from that part, you're going to see some sort of perforatory ischemia. It's, in the very beginning, it was a beautiful idea to use a longer, let's say, low porosity, high porosity construct, and then with a flow diverter. But with the existing devices, I do not believe that there is still need for that. Yeah.
One comment. I think the flow diverter in posterior fossa in the basilar trunk is limited indication, but your case, no atherosclerotic standard stent is standard aneurysm is good indication. But sometimes you are the radial force of the flow diverter is very low, and sometimes you are prolapse. The flow diverter, sometimes you are the prolapse or no good adaptation in the wall, and you are sometimes the endolink. I have a case with endolink. And about 7 years before, I treated the patient with another technique, is endoluminal reconstruction, is to put the stent and finally to put one balloon expandable stent, because you are very good radial force and stabilization of the vessel. I think from the industry, I need or I suggest develop the flow diverter stent. Is okay. You are many devices, but why not to introduce a new way to flow diverter or stent with a high radial force in the middle part, close to the neck, or in the proximal part, or in the end part, is depending of the size of the vessel. So you are the same size in the beginning of the vessel and the distal part, in the proximal part and the distal part, no problem. But in the basilar territory, many patients have the different size of the proximal part and distal part.
Yeah, there is a tapered version, but the key is the stent opposition. That's why after every flow diverter placement, we do some sort of flat detector CT angiography, just to make sure that there is no space between the device and the wall. If there is any, we do not hesitate to do the balloon dilatation of the device. Especially for weak radial force, it's mandatory. Okay, but with the higher radial force, what we see is that you put your device, such pipeline, in the vessel, and then 3 months later, when you measure the device, it's shorter now because it keeps enlarging, and then when it's enlarged and then opposed to the wall better, it gets shortened, right? But the key is not to leave any space between the device and the wall.
Do you think sometimes it's necessary to put some coils before, just to put some coils in the sac?
Yeah.
And then you deploy the flow
why not?
diverter. I think it's better to adapt.
When there is a little doubt about the rate rupture, that you got to protect the sac morphologically as well, one shouldn't hesitate to put either web or coil or whatever it is inside the sac, just to protect the sac of the aneurysm immediately. Yeah, well, if it's long enough, it's not going to move. Yeah.
I have a different question. Would you consider flow diversion in the acute stage of hemorrhage? For example, a patient with the distal vertebral dissection, which involves the pica,
yeah,
with only one vertebral artery. Would you What do you do? Do you wait or do you use the flow diverter at the acute phase?
Well, what we used to do, we used to wait for about a couple of weeks before we do the treatment. But now, for example, the last Naji show, the last ophthalmologist that she ruptured during the exercise, during the marathon running, we couldn't wait. We put the patient with 6 tablets of Effiant in the morning, check the efficiency of the Effiant an hour, 2 hours later, and when we saw that there is enough inhibition, we did the treatment the same day.
A very challenging question, which is if we diagnose an aneurysm, fusiform aneurysm, mid-basilar, prior to cause symptoms, the rationale to treat before it causes, because it's a crescendo of the disease, and maybe the morbidity may be less before the patient becomes symptomatic. So I guess the question is, what's your approach to that?
Well, this is one of I think the most confusing part of the treatment, because in most of the time when we decided to do the treatment for those non-segmental fusiform aneurysm, it's too late. It's too late because they are too large. There is no device for them. But you gotta your treatment. That's why at least there has to be one control examination that will show that the aneurysm is enlarging. Then there might be indication for treatment. But nonetheless, to propose some sort of treatment which carries at least morbid mortality 1/3, it's difficult, to propose the patient and the family.
Okay, thank you.
My pleasure.
Now is the stop to lunch, okay?
Ya estoy.
This was the best thing that we heard today. Yeah.
Fantastic.
Break for lunch.
¿Qué tal? ¿Cómo estás? Ah, sí.
Hola, no hay video.
Perfect.
¿Hay un descanso ahora?
I checked my computer and everything. Thanks.
¿Es un descanso ahora? Oh, sí, hay descanso. Okay. Oh, okay. Okay, muy bien. Podemos hablar. Simon, podemos unmute. Carlos, ¿tú estás allá?
Sí, yo estoy. Yes.
Hey, Simon, está allá, tal vez está durmiendo. Yo voy a sacar crédito para asistir a este congreso. Simon, ¿está allá?
No, además fui con mi novio.
Okay.
Y con él hicimos sobre
Okay.
salió bastante bonito lo que hicimos ayer. Y tenemos ayer las fotos, tiene él y tengo yo. Y aquí les guardo hasta que usted venga y ya hablo con el Cristian.
Okay, sí. ¿Sabes qué está haciendo Carlos? Estamos haciendo pruebas. Porque hay una pantalla y tal vez ellos pongan mí enfrente de la pantalla para hacer pregunta. Y tal vez tú también puedes hacer pregunta y muestra su cara. Pero
así es, exactamente.
Sí, estamos arreglando esto, pero es un cosa de progreso para subir, para tener progreso. Sí, porque
todos los cambios llevan mucho.
Sí, no, poco a poco llegamos para tener, porque queremos ser independiente, no necesita tener una compañía grande para hacer estas cosas. Solamente necesita tener espíritu de explorar y necesita amigos en IT IT es importante para tener
Ya.
que ellos, como Perla Negro, que quiera experimentar, quiere escuchar.
Ujú.
Sin ellos es difícil. Sin ellos.
Sin ellos es difícil, así es, o sea, no se puede hacer muchas
Sí, tú
cosas.
no tienes tiempo, yo no tengo tiempo, no conoce mucho de esto,
Ujú.
pero tenemos una ventaja en San Carlos y conocemos, un técnico está allá de nuestro equipo, está en San Carlos ahora.
¿Quién, David?
No, sí, su amigo, David va a venir mañana.
Ajá.
Hoy no, su compañero José está allá hoy.
Bueno, pero lo importante es que lo está haciendo.
Sí, está allá, está probando. Prueba esta mañana, yo estoy enfrente, pero el sonido no es bueno. Entonces, cuando él regresa de comer, nosotros vamos a prueba más
Ujú.
para tener el sonido que para oír su pregunta. ¿Y qué hospital está? ¿No está trabajando hoy?
Hoy aquí ya es las 2 de la tarde, 2 de la tarde. Entonces yo...
Ok, sí, aquí es 8.
Claro, allá, a las 8 de la mañana, ¿no?
Sí, empieza a las 2:30 hoy, el congreso.
O sea, hay 30 minutos de descanso.
No sé tanto, yo creo 15, yo creo.
Ujú.
Sí, tenemos una persona de PEX hablando. ¿Tú reconoces su nombre?
The pitch es Hudak Istvan.
Sí, tú no conoces. ¿PEX es un país o qué?
No, Pécs es una ciudad de Hungría.
Oh, es una ciudad, ok.
Ajá. Yo trabajé, Hudak Istvan era mi compañero de trabajo.
Oh, ¿tú conoces a él?
Sí, es que es mi compañero de trabajo.
Oh my God, tú vas a tener sorpresa si tú estás en la pantalla. Él va a pensar es fantasma.
Sí. Porque yo hablé con él, déjame ver, ¿en qué vez hablé con él? Yo creo que en verano hablé con él, que estaba yo por Hungría. En septiembre, por ahí hablé con él.
Sí, cuando tú estás allá, la última vez.
Sí, la última vez que estuve ahí estábamos hablando, pero estaba bien y ya me comentó acerca del congreso que iba a haber en Madrid.
Oh, sí, él habla que va allá.
Ujú, sí, él ya me comentó, yo ya sabía eso.
Sí, yo creo que cada año él va, yo creo.
Sí, esta es la segunda vez, ¿no? Este es el segundo año que están haciendo.
Oh, segundo, ok. Porque es nuestro tercer año de hacer esto.
Ah, es el tercer año ya.
Sí, tercer año.
Ujú.
Sí, ¿qué?
Yo les pasé el link del YouTube a unos radiólogos de aquí de Ciudad Real para que lo vean.
Sí, venga. Bienvenidos a todos.
Sí, ya les pasé.
Ok, qué bueno. Sí, tal vez probamos a poner en la pantalla, tal vez sirve.
Ajá.
Vamos a investigar.
Sí, habrá que ver si están en línea.
¿Está en la línea ahora?
No
Sí,
lo sé, ya les voy a preguntar.
ok, porque tú puedes pasar el link que tú recibes de mí, este
Ya,
link para entrar directamente.
ya les voy a enviar ahora.
Sí, ok.
A ver.
Small world, un mundo pequeño.
Sí. Juda, que es uno de los mejores radiólogos neurocirujanos intervencionistas a nivel Europa, o sea, es bastante conocido.
Sí, bien conocido.
Ujú.
Sí,
Sí.
Luis tiene un buen personas en este congreso. No hay mucha gente allá
Es
asistiendo.
que está seleccionando gente de todos los países, me imagino. ¿Cuánta gente está en el Congreso?
No mucho, 20, 30, menos que 20, 30, nada más.
Uf.
Esa es la razón que yo quiero desarrollar esta cosa porque es buena calidad. Pero
Sí,
pues tiene radiólogos de Argentina, de Finlandia, de Chicago, Japón, yo creo. Tiene
sí, están de
India.
Japón, de la India, está de Turquía,
Sí, Turquía.
de Finlandia está uno de los mejores
Sí,
neurocirujanos vasculares, Hernies Niemi.
Sí, Juha, ¿verdad?
Sí.
Es famoso este hombre, ¿ah? Yo creo
Trabaja mucho.
Sí, Juha, wow. Sí, él es famoso este hombre. Finlandia tiene muchos neurocirujanos activos en Internet.
Sí, también, y les gusta trabajar. A mí me encanta cómo trabajan ellos. Tienen un buen grupo, se dedican a trabajar.
Sí, estoy tratando de entrar a este grupo, pero no tengo suerte. Juha es demasiado ocupado. Él va a muchos congresos. Wow.
Va a muchos congresos y poco tiempo para trabajar.
Sí, más congresos que trabajo, yo creo.
Pero él ya tiene la edad, o sea, él ya podría hacer eso. O sea, ya poco, tiene muchos colaboradores con los que puede trabajar.
Ajá.
Entonces
Hey,
eso
Simon.
le...
Hey,
Hi,
Simon.
Carlos.
Mira, Carlos.
Hi, Carlos. Nice to see you.
Nice with you. See,
Long
hello,
time.
Simon. How are you?
Hi, fine, thank you. Japan is cold, as usual.
Here in Kindergarten is in Spanish too, because we have in about -1 and 5 grade centigrades.
What, in Madrid?
En Ciudad Real. Yeah, it's cold.
See? Wow, yo
Yeah.
pensé que Madrid no es frío.
No, it's so cold.
Sí? Oh.
Yeah.
Sí, Miami, 70 grados.
¿Minus?
No. Es caliente, no caliente, pero temporada. Es bueno.
The 17, yeah, I think. Yeah.
Yo voy a mostrar. Déjame ver. Tú vas a estar celoso. Sí. Sí, al sol.
Oh, it's nice. We need to stay there.
Sí, al sol.
Yeah.
Hay mucho sol por ahí.
Sí, mucho. A veces demasiado. Pero sí, sí, no sirve en Ecuador, los técnicos no quieren hacer el último congreso. ¿Recuerdas?
It was a very few time for us because I was here in Spain, and when I back to that, I have just one month to prepare all things, and the technicians was very worried because they didn't have any time. In the next March, there will be a congress of clinical and surgical congress from the same hospital. But I am not the organizers. I will be just gave a conference about neuronavigation, and after that anymore. But I am not sure that if they are interesting to transmit this congress, but maybe I need to ask them.
Okay.
Yeah.
Okay. Sí, es poco callado ya. Y no está haciendo mucho en español. Nosotros we're going to televise a workshop from India, I think, next week. A neurosurgical workshop. You know, disecciones y operaciones, yo creo. Estoy tratando tener un rehearse para preparar. 18, 19. Yo creo la próxima miércoles, jueves. Yo voy a mandar email.
Yeah, because on Sunday I will go to Hungary, and I will back to Spain on Wednesday.
Okay.
Yeah, I will speak with the Hudak here there in Hungary too.
What's that?
When I go to Hungary to pitch, I will be speak with the Hudak, the people who is speaking now.
Oh yeah. I told Simon that que coincidencia. Simon.
I'm here. Sorry, I'm eating dinner at the same time.
Yeah. Carlos came, and by coincidence, one of his associates from Hungary,
one of the radiologists.
One of the radiologists is speaking.
Oh, really? Wow.
And so when Carlos comes on the screen in front, he's gonna think it's a ghost.
Yeah. That'd be great.
And Phantasma. So yeah. So Madrid's your home, right, Carlos?
No, my home is in Ciudad Real. It's next from Madrid. It's about 200 kilometers.
Oh wow, it's a different city, Ciudad Real.
No, it's the same. It's not enough.
200 miles. It's a long way.
For me, it's better to stay here in Ciudad Real because it's a little town. It's about 60,000-70,000 people living here. But they have a lot of things here: the high school, the university, the hospital, all things. And I have the two kinds, little kinds, and for me, it's enough.
Right. Yeah, it's tough to live in a small town. It's not easy, especially a neurosurgeon, right? Neurosurgeons need a big town, right, to have enough work. So how when you go back to Ecuador, Carlos?
I will back at the end of this month.
Okay, so are you trying to set up a network of neurosurgeons there, or are you trying to do something with the system of education of neurosurgeons in Ecuador?
At this time, they starting with the neurosurgeons specialization, but there they didn't have any kind of results. It's so difficult to do something.
Yeah, frustrating, huh? Frustrado. Sí, cosas muy lento.
Yeah, all think is this.
Well, tú conoces Latinoamérica, es así. Yo vive en México, es lo mismo. Lento. Hay dos rapidezes. Lento y alta. Okay. So how's your family, Carlos?
It's so good. It's good.
Are they in Ecuador?
No, they are here in Spain.
Oh, wow. So do they come back and forth to Ecuador, or they stay in Spain?
And no, my family is living here in Ciudad Real. I am going alone to work in Ecuador.
Oh, okay. Okay, but they were there before, right, in Ecuador? I see pictures of them.
Yes, they was before that in Ecuador for 8 months, but they didn't like it to live in there.
Okay.
And they come back here.
Oh, okay. They like Ciudad Real better? Mm-hmm. Too small in Ecuador?
Yeah.
Yeah. The schools very good or no? No good.
In Ecuador, they have any kinds of schools or any kinds of education possibility, but all things is too much to pay for that.
Really?
Yeah, really. Because, for example, it's in a private high schools about $2,000 dollars for 1 month.
Wow! 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 But it's the only good education, right?
Yeah, if you want, yeah. If you want to a good education for your kids, you must pay for that.
Right. Okay. Here they have good public schools. You don't have to pay.
In Ecuador, is the same. There are so many public schools, but I think the quality of the schools is not good.
Yeah. So Spain, you don't pay, right? Public schools?
Here in Spain, the public school is good.
Yeah. It's the same in this country. The same as this country. That's one thing. If a country values education, it's a good thing. Educación es el futuro, right, Simon? Right. There you go.
So we're waiting for it to restart again? Is that what's happening?
Pretty soon, I think.
I see.
Hasn't started yet.
Who's coming up first?
Let's see.
Who's on first?
Let's see what we got here.
Can I ask a question to Carlos?
Oh, yeah, sure.
Is Carlos around?
Yeah, go ahead. Go ahead, Simon.
Carlos?
Please tell me.
Oh, thank you. John and I, we broadcast quite a few of these radiology conferences, and to a student, a lot of this seems the same, coiling, for example, and a lot of it's above my head. But to a neurosurgeon or to a radiologist or an IVR person, what is very significant, or what is the reason to attend the conferences? What is exciting about it? Are we seeing a lot of new things?
I think all people who, for example, when in the case of the students, it's important because in the university it's not enough the explication for some kinds of pathology or some kinds of techniques. And for that, the medical students or the residents wanted to go for these kinds of congress. But I think for here in Europe, it's not frequently these kinds of participation. But for example, in South America, when they live in these kinds of surgery, there be about more one quarter or half assistant people is just a student.
Mm-hmm. Because when I look at the audience, there didn't seem to be a lot of people in the audience. But of course the questions are very technical and from professionals. And I guess this information has to be, valued and kept so it's not lost. I often wonder that when I see some of the conferences that a great speaker gives a speech, a presentation, and then it's gone. And I think, wow, what a waste, more people should have gone to see it. But I can recognize that, a specialist, I suppose, is asking specific questions. Are these things that when a specialist asks a question at these congresses, are there things that are really something new or something that has never been seen before? Or do you see a lot of the same questions come up?
I think they have all three things because, for example, when you are going to some congress, you will be here or you will see something new in the medicine areas. And for the other side, for example, when you have some kinds of knowledge of some pathology or some technicals, in these kinds of congress, you can acquire more more opinion about that.
Okay, so
yeah, and for example, for the young doctors or the young people who start in the university, this will be helpfully in their orientation in the later time because they basing on that data, they can select what kind of specialization can do it for that.
I see. Wow. Thank you. That's a good reason to watch it. We have a lot of people in our neurosurgery forum, and when we announce the conferences, we get lots of likes and etc. But really, few people show up. And I wonder if it's because of a fear. They feel they don't have enough knowledge to participate in the panel, or they're embarrassed they can't ask a question. But I can see that it's good for every level, from the beginner to the expert.
Yes, it is important because I think in the medical education is not enough, because always you are study and study.
Yeah.
So, for example, when the people speak in some kind of congress, when they give in the conference, they are study too. Because, for example, when I do it, my conference, I must study what kind of things are newly, what kind of things are changed in the last time, because we need to have a lot of know. We need to study every time. I
It's
think
fast changing. It changes that fast.
I think actually in medicine, it's so many things is changed in less than 2 or 3 years.
I see. Okay. Yeah, I think it's just because my level is so low. I just don't recognize a lot of the things, and so. But I noticed that there's some heavy questions, and sometimes even it sounds a bit angry, even in a way. Sometimes people very frustrated, and I guess it's because it's that important, You have to figure out the right way. Okay, well, thank you. I was wondering about that. That needs to be told to the students who are, a forum, why they need to come and watch.
Okay. Well, we should be starting shortly. Yeah, hopefully we'll get this live questions on the screen there. You know, the audio is the question, dog, because they have to get, like, you know, the screen on the stage. You know, they don't have the audio speaking, because normally the screen is just, you know, showing the image.
Yeah.
So we have to figure out. They're trying to figure out a way to put audio onto the question.
I see.
But the solution that he came to most recently is basically they put the screen up, because I had my picture up there. However, they couldn't hear me talking.
Okay.
So apparently he has to manipulate that from his computer, of putting the audio on my screen, and then I'm muting, and then he changes it to something else.
That'd be good for questions from the world, right?
Yeah. If we can make that step, it'll be a good step. If we can show someone coming in from outside with their face and hearing the question, that is a big step.
Yeah.
Then I can tell Julio Mayal, look at what we've done.
Yeah.
But so far I can't really. It's just, you know, televising, live stream a conference. But I'd like to show them we can bring people from around Latin America. Then I can
text. I suppose that's the first step.
Yeah, that's the first step. If we can show that we can bring other people from Latin America into San Carlos Clinic, it can be a center. I mean, this guy's an innovator. This guy's big in Spanish medical education, and I think he would listen if we did something different like that, and we're able to say, hey, you can do it in any specialty from San Carlos. Apparently, San Carlos is a really good hospital in Madrid, and we've got a break to do this. Really, that's what I want to, you know. Well, I'm just thinking, you know, it's outside shot. There are a lot of outside shots, but one's going to hit. So
yeah, I see what Carlos was saying, you know, and it should be more of an appeal to panel members. And, you know, in the forum, we have so many who give the thumbs up and look like they're interested. But I think there's a fear factor, for one, that they don't have anything to contribute. And second, people are wondering what, you know, why go?
Well, yeah, we like people like Patty Pacheco. She'll jump in and anything. And you know who was here was Marco from. Yeah, he goes to everything. I mean, some people just like it, you know, just what the hell. And Marco's not shy. He'll say, I don't have any questions. No problem. Right. But I guess I think it's mostly because people think they have to, you know, ask something intelligent. You know, they feel they'd rather just watch it online.
And I think the word panel member makes people feel like they have to be.
Yeah. Maybe if you change that, maybe you should say spectator. Yes. Oh, by the way, we're live now.
Yeah, I know.
Yeah. So don't mention any old girlfriends' names and stuff.
How many watchers do you have?
Oh, I don't know. Right now, it's not accurate, really. That's what I say, anyway. It says 5, but I don't know, because I've got it posted on a bunch of different boards like Facebook, Google Plus.
Well, each one stands for a million, you know.
The websites. Each one stands for what?
Million.
Oh yeah, there you go. There you go. It's the scale. But yeah, it's taking a long break there. I hope we haven't lost contact. I don't think so. Jose, are you there? Oh, I think he's there because the screen's still there. Yeah, every time I talk to Louis says, "Oh, you coming to Madrid?" I said, "Man, yeah, I'd love to come to Madrid. Maybe next year. Maybe next year. I just have a feeling something's going to happen this year, and so that we'll be able to go personally to Madrid. Nice auditorium, huh?
Yeah.
Really nice auditorium. Good screen.
Why is it there are so few people there?
Well, I think I don't think it's really promoted a lot because they have other there's another NeuroInterventional Radiology Conference from Paris that it looks like it's very well attended and very, I think they spend a lot of money promoting it. I ran across the website and it looked like it was pretty full.
And they don't take personal copies of those videos or keep them away in a CD-ROM?
Geez, I don't know. I don't know what they do. But last year, Dave made commercial. He made a really good commercial. Did you see that commercial? Yeah, he had guys give testimonies almost of how they liked it and this and that. We tried to arrange this so that with a company from Brazil, but that just didn't pan out. I don't know if I don't know. I don't know what Louis wants to do with this conference. He's a busy doc. I think he's kind of doesn't have time to promote it and stuff. He has a big mailing list, and I use the mailing list to send to people, but I didn't get much of a response.
Mm-hmm. Yeah.
I just said really, there's one doctor from Texas that wrote me and says I might be on the panel. But from the other 400, there was a mailing list of 400. I think it's just so new, the tech's so new, and they probably don't. Panel. Oh, I don't want to be in the panel. They're gonna grill me. So
tough stuff. It's better to be it's almost to be a student. Knowing nothing is good once you.
Yeah, you always got an excuse.
I'm not expected to know anything, so
yeah, you always got an excuse. But even as a student, I felt the pressure to say something, Yeah. But who was good at that? Remember the student, one of the students that used to come to the neurosurgical hangouts. What was his name? Real quiet guy from Philadelphia, I think.
Yeah, I know.
Remember your buddy?
Yeah.
He used to say, "No, I don't have any questions." And it was, fine, no problem.
Yeah.
But I was too shy for that. I'd make up some bullshit question that sometimes didn't make any sense.
What is the airspeed velocity of an unladen swallow?
Oh, that's Carlos. You said extraordinary. Oh yeah, great.
What happened with the Congress?
I don't know. I think they're taking a siesta, Carlos.
I think we have 5 minutes more.
No, I think it's a siesta. They're taking a nap.
Do you see the program?
I see the screen. Maybe I'll check with Jose. Let me check with Jose. See, make sure everything's okay.
Yes, we need to see when we restarted the Congress.
Yeah.
Because
Carlos, you have an interesting life, though. You get to travel the world. Every time we connect with you, you are in Hungary or Spain or another country.
it's a not easy life.
This is because you are maybe an expert in your area, so you're going to teach and learn.
Yes, I think I don't know what my life is doing in this way.
Just
when I began studying in Hungary, I working there. And after that, for one invitation, come to work in Spain. After that, I going to Ecuador, and for now I am not very well. What's the best for me? if I continue my life here in Spain and in Ecuador, or if I back definitively to Hungary. Yeah.
Yeah, that's it.
And Tony, then you have privileges at hospitals in Hungary, in Spain, and Ecuador too.
Yeah, I have this kind of things, but I am not. I am tired now because I didn't like to do every time to take a plane, going to Ecuador, back to Spain, go to Hungary.
Right.
So it's the years.
So you have to pick.
Come over us.
You want to pick one place, or you're going to two places?
No, I have in Ecuador. I have one a great place there in Spain too, and in Hungary too. But at this time in Hungary, I am stopping my work there. I'm not working there. I just go back, and sometimes when they needed some kinds of opinion for me of some kinds of on a difficult session, we can do it with other people. So I working more here in Spain and Ecuador at this time.
Okay.
But my target, my purpose is to back definitively to Hungary, maybe in 2 or 3 years. But I will be trying to do that.
Oh, okay. Okay, sounds good. You know, Simon, maybe we should end this hangout because right now we're running on. Excuse me, Carlos. We're just. Oh, okay. Oh,
You're
yeah.
running on the fumes, huh?
Oh yeah, he's just talking to. Oh my. Oh man, this Jose guy. He's doing an interview with Lewis. Well, thanks a lot, Jose. Man, oh man.
Oh. John, people will be restart at 15 hours. So it's more than half hour now.
Yeah, you know, maybe Simon, we should start another one because this is running on.
Okay.
What do you think? 6 hours now.
Yeah, I think it's better to let it go because we can't download the video.
Okay. All right. I'm going to send you another link, Carlos. I'm going to start another hangout.
Yeah.
Okay.
Yeah. Okay. Bye. Bye. No, man.
¿Ves, papá, cómo lo he hecho así para que no me vean? Y sin más, ven a comer.